Ma'am, we are live in 3, 2, 1. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Oncology Update 2022 and beyond. And with immense pleasure, I would like to invite Dr. Devesh Goyal, who is Consultant Medical Oncologist, Fortis Hospital, Jaipur, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah, thank you. Just in brief, today the CM is Oncology, this update 2022 and beyond. And this conference is comprised of 2 days. First day, we will discuss on this breast cancer, and second day is the GI and GU cancers. So basic aim of this today, the talk is to update regarding this HER2 breast positive cancer as well as the ER/PR positive, the hormone receptor positive breast cancer. So just the nowadays the breast cancer scenario is changing day by day. So just for this we are today conducting this CME, and purpose of this CME is to update the every aspect regarding the treatment change sequencing and our basic focus on this the real day-to-day practice in our clinical scenario. So the few topics will discussed followed by the panel discussion. So without wasting the time, I invite Dr. Asim Samar for the first talk. Basic on this test, he is senior consultant medical oncologist and Bhagwan Mahavir Cancer Hospital, Jaipur, and he will deliver the talk on the two topics, that is the Destiny Breast 04 trials as well as the Unique Cancer Esther 70S trial. So over to Dr. Asim.
Thank you, Dr. Devesh. So my slides are visible to you all?
No, just please share.
Just a minute. Now I am sharing that.
Yes, your slide is visible.
Let me do the full screen. Yeah, it's visible and it's moving, I guess, right?
Yes, sir.
Yes.
Slides are moving perfectly,
Yes, sir.
right?
Yes, sir.
Okay. So thank you, Dr. Devesh Goyal. He is my very good friend and very nearby to our institute, Bhagwan Mahavir Cancer Institute. Fortis Hospital is there in Jaipur. So today we'll discuss the very enthusiastically present paper in the this year ESCO 2 months back only, and Dr. Shanu Modi has presented, and she is the main researcher in the Memorial Sloan Kettering Institute, US. And the beauty of the thing is she is a basic scientist, and she works only for the HER2 positive breast cancers. The whole team is working for that, and now they have come up with this wonderful drug. So the trial name was Destiny Breast 04, and here they tested trastuzumab deruxtecan. This is the trial drug versus the treatment of physician choice in the patient with the HER2 metastatic breast cancer. Results of HER2 positive means HER2 low positive, unresectable and metastatic breast cancer. So this HER2 low positivity is the patient where the targets were not available, and now they have come up with a very good drug and very good results. So they presented in the 5th June 2022 Sunday, and after 1 month only there was a publication in the NEGM, and full support across the world was given to this article and this trial results. So this is the lady who presented that, Shanu Modi, and she is the scientist come medical oncologist there. So the slides were exactly the same which was presented in the ESCO Destiny Breast 04. So we were discussing about the HER2 positive group. So what is the current paradigm of metastatic breast cancer is we get the patient 15% patient who are clearly 3+ HER2 positive by IHC. So this is the this subgroup we are now talking about. Now we are talking about the subgroup where the HER2 is low positive. That means either they are by IHC they are 0, By IC, they are 1 plus or 2 plus positive, but negative with the fish. And this comprise of the 65% of the patient, and 15% patient are hormone receptor negative and HER2 negative, that is TNBC. So this larger chunk, this therapy can target. So this is the impact of this particular drug. And now this what we are talking about is HER2 positive breast cancer. We will not discuss. HER2 low positive, again same thing, ISC 1 plus or ISC 2 plus, which we know nowadays equivocal, and we need to confirm with fish, and it is fish negative. This is non-amplified. They were taking into this group, Destiny Breast 04 trial group, and they have taken few patients of the hormone receptor negative also in the low subset. This is the triple negative breast cancer patient. So just for our understanding, we know like it is the clearly negative ISC, 0 ISC. That is score is 0 by ISC. 1 plus is the membranous staining is barely visible or perceptible. If 10%, more than 10% cancer cells have the membranous staining, but it is not very complete, then it is a 2 plus, and we need to further confirm with the fish test, and this is the clearly positive, the 3 plus. So we are not discussing about this patient subgroup, and we are not discussing about this one. Only we are discussing about this or this, and this is true when it is negative by the fish. So what is the current standard of care treatment is, if patient is HER2 negative, or now we are knowing it is HER2 low, but earlier we used to say it is HER2 negative. So if they are hormone receptor positive, we used to give them endocrine therapy if they cannot afford the CDK4/6 inhibitor. So endocrine therapy or PARP inhibitor if they are germline BRCA1 positive. If patient are hormone receptor negative and HER2 negative, then we used to give checkpoint inhibitor like immunotherapy, PD-L1 if they are PD-L1 positive, or newer antibody drug conjugate that is sacituzumab, govitecan, Trodelvy, and if the patient progresses, then only left option was a chemotherapy. So this subgroup which is hormone receptor positive and HER2 low positive have a very little to offer. So they have discovered this group, and they tried this drug. Again, I will read this. HER2 low metastatic breast cancer is defined by the ISC score 1 plus and 2 plus ISC and fish negative. HER2 low MBC is treated with the like a HER2 negative metastatic breast cancer with limited option for the later lines of therapies, and therapeutic option for the patient with hormone receptor positive HER2 negative MBC after CDK4/6 inhibitor is over progression has a very limited efficacy, and the real world study suggests that PFS is less than 4 months after progressive disease on the CDK4/6 inhibitor, which is very troubling subgroup. If patient has this much resistance with the CDK4/6 inhibitor, we have very little to offer them, and limited benefit exists with patient who progress after multiple lines of chemotherapy. So in a pooled analysis of patient with HER2 negative MBC, eribulin and capecitabine, which we usually use, they provide very minimal benefit, and the median PFS was only 4 months and median survival was 15 months. So this difficult population group they targeted with this newer drug. A little bit about this design of this antibody drug conjugate. This is a trastuzumab, and they have a test one topoisomerase inhibitor payload. This is the payload, and this is a highly potent drug, and this was linked to this antibody with this cleavable linker, and the antibody to drug ratio was 8:1. Remember, we have another previously available TDM1 where the drug to antibody ratio is 4:1, and in the Destiny 03 trial where the head-to-head comparison was done with the Tdxt with the TDM1, Tdxt proved to be very superior, just probably because of the ratio of the drug to antibody drug conjugate. So what is the mechanism? We give the drug, and this is the HER2 receptor. This trastuzumab portion binds to it, then endocytosis of the drug happens, and here in the lysosome the drug just cleave off with the cleavable linker, and this payload is going to the nucleus of the same cell and another cell. This is known as a bystander effect, and this is why this drug is active against the HER2 low subgroup. This is the proposed mechanism, and it has been proven in the other trial also. Just go to the previous slide. One important thing. So they have confirmed this mechanism of action in one phase 1b study, where they have reported efficacy of Tdxt in heavily pretreated patient. They have taken 54 patients, and in the HER2 low MBC with median PFS of 11.1 month and overall response of 37%. So heavily pretreated patient and HER2 low positivity, where we just say like where supportive care, they have tried this drug and the response rate was 37%. So this was amazing, and then that set the ground for this Destiny 04 trial, and it is the randomized phase 3 study, open label and multi-center and multinational study. And I can say it is a multi-continental also. It was done in America, Europe, and Asian population. So how they stratified the patient? Patient were HER2 low positive, unresectable, and or metastatic disease with the 1 to 2 lines of prior chemotherapy in metastatic setting, and they were hormone receptor positive, consider endocrine refractory if they relapse within 6 months. So the patient has de novo metastatic disease, you have started hormone receptor, anti-hormone receptor therapy like endocrine therapy or CDK4/6 inhibitor, and they relapse within 6 months. They have taken up in this population. So it was the binary randomization, 2:1 randomization. Tdxt, one arm was Tdxt and other one was treatment of physician choice, where they have given capecitabine, eribulin. The physicians were given the option of choosing capecitabine or single agent eribulin or single agent gemcitabine, paclitaxel or nab-paclitaxel. And there, later on we will discuss in how many percentage of patient which drug was given. So hormone receptor positive patient were 480, and they have taken the hormone receptor negative. That means they are triple negative. By this current definition, hormone receptor negative and HER2 low positive. So it is triple negative sort of the patient. Primary endpoint was PFS by the blinded independent review committee in the hormone receptor positive. This was the primary endpoint. And the key secondary endpoints were PFS by BICR in the all patients or overall survival in hormone receptor positive and all patient, means intent to treat population. And this is the patient disposition schema. They have screened around 700 patient and randomized 557 patient, 373 patient in the Tdxt arm and TPC arm 184 patient. So it is 2:1 randomization. Currently, when the data cutoff was presented, first study result, ongoing study treatment was in the 15.6% of patient, and 84% patient has touched the endpoint and they were discontinued the study. 1.3% deaths were there in the experimental arm. 1.3% means like almost 4 patient died, and adverse event were happen in 16.2%. Progressive disease was in 60% almost, and withdrawal by subject means patient withdrew the consent in 3.2%, and others is 4.3%, where the loss of the follow-up were involved. TPC, you see like death were 1.2%, adverse event 8.1%, progressive disease 75.6%, withdrawal by the subject 6.4%, and others were 7%. Here is the in our interest which drug they have used. So to our surprise, they have used in 50% patient eribulin. The physician chose the eribulin. So generally we don't give this kind of the thing, but they have chosen like 50% doctors have given eribulin. Then they chose capecitabine as a second option, means 20% doctors have chose the capecitabine. 10% patients were given nab-paclitaxel, 10% were given gemcitabine, and 8.2% were given paclitaxel. In real life, we usually more than means if you just survey the doctors, almost 50% in India will give the paclitaxel or nab-paclitaxel. So this was the small difference with us. So age was say 50, median age was 57 years, and male to 99% were female. So almost 4 or 5 patients were male also. This is very interesting thing. Europe and Israel encompasses of 45% population in the hormone receptor positive group. This is the largest group, and Asian population was in 40% patient had were the Asian population. North American was 16% where the trial was done. HER2 1+ was 58% and 2+ and FISH negative were 52%. ECOG PS were taken 0 to 1. Hormone receptor positive were 99% patient and 1% patient were hormone negative. They have taken the brain mets positive, inactive brain mets and liver metastasis. 75% patient had a liver metastasis, lung mets 30%. In India, usually we get more lung metastatic patient and less in the liver. Prior therapies, so this is important thing. They have taken the prior lines of therapies, systemic therapies, at least 3 average. So 1 to 9 lines they have, and one line previously failed on one line was 7%, 2 lines failed patient was 26%, and 67% patient were failed into prior 3 lines of the therapy. And here you can see 60% patient had received at least one line of the chemotherapy. Endocrine therapy average they have taken 2 lines and prior targeted therapy. So you can see this is important thing. Like in the hormone receptor positive subgroup, 78% patient in total, they have taken the targeted therapy, out of which 70% patient had taken the CDK4/6 inhibitors. And here the result comes. So this is the unprecedented PFS increment. If you see, like in the control arm, like where the patient has received treatment of physician choice, it was the PFS was 4.7 month median PFS, and here in the experimental arm where the Tdxt was given, so it was 10.1 month in the hormone receptor positive subgroup. So it was the key primary endpoint, and they have achieved very well. P-value was highly significant. P-value was 0.0001, and the hazard ratio was 0.51. That means 49% patient has decrease in the death or recurrence. So this was very significant, and this kind of the hazard ratio means like everyone's dream, but they have achieved that. And if you see in the old patient, it is not very different. In the Tdxt arm, the PFS in all subgroup, it was 9.9 months, and p-value was again significant, and the hazard ratio was 0.50. So this was significant. If you see the overall ratio in the hormone receptor positive patient, overall survival was 23.9 months, and here it is overall survival was 6.4 months median survival. So it is a highly significant, you can say it is means like 3 times 4 times. The hazard ratio was 0.64 for the OS. So 36% patient had a reduction in the risk of death or recurrence, or in the OS it is death only. Here, if you see the across all subgroup, like intent to treat analysis, in the control arm it is same, but in the this one Tdxt arm it was 23.4 months. So there is no major difference between 2 arms. If you take the older patient or hormone receptor positive patient, almost it is 23 months. If you see the exploratory endpoints, it is like PFS and OS in the hormone receptor negative, that is you can see the triple negative population. It is 5.6 month in the control arm, and it is 8.5 month in the Tdxt arm. So you can say Tdxt works in the hormone receptor positive negative patient also, triple negative also, and same is true with the overall survival. In the triple negative, if the patient fails multiple lines of the chemotherapy, 1 or 2 lines or 3 lines, the overall survival later on is 9.9 months, and it has just doubled in the Tdxt arm. So it is wonderful drug. And this is the forest plot. 1 or 2 important thing I will mention. Patient, if the patient received CDK4/6 inhibitor, still they respond. If they haven't used this drug or some endocrine therapy other than this have taken by the patient, the response is better. ISC 1+ has a very good response, and ISC 2+ is just similar response. But if you see the patient who were Asian in origin, they responded very nicely. Best response was seen in the Asian population. Here also, region-wise and race-wise, Asian population. Race is like if the patient were Asian and living in the North America, they responded well. And region-wise, if the trial were done in the Asian center, their response was pretty good, the best actually. So this was important. And now the confirmed overall response rate. These things we love to see because medical oncologists want response and patient also. So in the hormone receptor positive patient, 52% patient had a response with the Tdxt, and in the physician choice chemotherapy, it was 16.3 month. If you see the hormone receptor negative, it was 50% and it is 16.7% response rate. And duration of response was also 10.7 months, which is significant, and TPC it was 6.8 months. This is a waterfall plot, and you can see the difference between these two arms. You can see like Tdxt, the response with the Tdxt, like tumor shrinkage was done in the maximum number of the patient, and here the number is little less. Now the real clinical practice. Drug-related AEs were seen in more than 20% of the patient. The most common AE was the nausea. It was seen in the 73% of the patient. Fatigue was seen in the 48% of the patient, and 8% had a grade 3 fatigue. Alopecia, vomiting, and neutropenia. So neutropenia was seen in the 14% of the patient. Other rest were decreased appetite, thrombocytopenia, transaminase increment, and diarrhea and constipation. But one very interesting side effect was the pulmonary toxicity. So you can see median treatment duration was with the Tdxt was 8.2 months, TPC was 3.5 months. Most common treatment related adverse event leads to discontinuation was ILD or pneumonitis. Dose reduction was done because of the nausea and fatigue in the 4.6% of patient. In TPC arm neutropenia, we usually do this, and the on treatment death. So this is very important thing. Almost 1% patient had a death because of the Tdxt, and the responsible cause was generally the fatal pneumonitis. So adverse event of special interest was I'm just let me check the time. So I'm overshooting 2 minutes, I guess. Adjusted age-rated drug-rated ILD or pneumonitis. So almost 12% patient had this 3.5, 6.5, 1.3. So 12% patient had any grade of pneumonitis, out of which 3 patient like 0.8% had a grade 5 month. They died because of the death happened because of the pneumonitis. So this is the important side effect, and they have put the very strict monitoring protocol. They do the CT scan, HR-CT every 9 weeks to control this particular side effect. And Tdxt has a ejection fraction decrement in the 4.3%, and cardiac failure was in 0.5, 2% patient had a cardiac failure. So in summary, Tdxt, this is the last but one slide. Tdxt is the first HER2 targeted therapy to demonstrate unprecedented, statistically significant, and clinically meaningful improvement in the PFS and overall survival versus the physician choice chemotherapy, and similar magnitude of benefit across all the subgroup, including HER2 ISC status or prior CDK4 use, CDK4/6 use. Safety is consistent with the non-Sept profile and showed an overall positive benefit risk. Destiny Breast 04 establishes HER2 low MBC as a new targetable patient population, and Tdxt is a new standard of care. And this is the summary slide. So Tdxt is 9.9 month PFS, and in overall survival it is 23.4 months. So this was so impressive presentation, and then in the plenary session, in patient, the listeners or audience has given the standing ovation to this lady Shanu Modi. And this is a drug Enhertu, which is developed by Daiichi Sankyo, and this is marketed by AstraZeneca. So thank you very much for your patient listening, and I'm happy to take question and answer if the time permits. Thank you, Dr. Devesh and organizers. Over to you back.
So Devesh, sir, you need to unmute yourself. We are
So sorry. Thanks, Asim, for this wonderful talk. And I think each and every aspect of this trastuzumab deruxtecan was very clear. In each and every aspect, the drug is better, PFS, better OS, I think, with minimal side effects with proper monitoring. So I think the scenario in HER2 low positive, I think extremely changed in coming years. So I think we will focus on this HER2 low positive patient on this treatment aspect. So I think Dr. Asim, just want to ask when this drug is available in India. So from this after 6 months or 1 year.
No, this drug is actually our center is running a trial with this drug, Destiny
Okay.
06. So it is available in our center, but in different setting. So and very near future commercially it will be available. So DCJ is conducting. They are conducting the trial for the DCJ approval, and in our center this is available. So if you have a suitable patient, Dr. Deepak Gupta is the PI for the trial, so you can send us.
So definitely we will enroll, and I think we will all the patients of this HER2 low positive patient will definitely get benefited for this drug in coming years. So when this drug is available in market. So any query from Dr. Lalit sir from your side?
Yeah, in fact, thank you so much, Asim, for the excellent overview and talk. And I feel, in fact, many patients who are HR positive with low HER2, 1+ or 2+, that may be possible reason that many of these patients, they do not sail through well, and we are missing, in fact, this important target. So it looks the future that rather than missing those HER2 low positive, this is a wonderful drug with different drug delivery system. So I think this is very, very important, enlightening improvement in our knowledge. And probably in coming few years, we will have more and more of such molecules. And Dr. Asim has covered it excellent way. Truly loved that part. Thank you so much.
Thank you, sir.
Thank you, sir. Thank you, Dr. Asim. So move on to the second topic. So we will discuss on the second part, the management of HER2 positive metastatic breast cancer. So this session was sponsored by the Roche, and for this I invite Dr. Mukesh Rania, who is assistant professor in Department of Medical Oncology and BMT SMS Medical College Jaipur, and he is my junior in the GCRI. So he will enlighten the facts. So that is the transform the journey for your HER2 positive breast cancer patient. So I think the Roche is launched these molecules, and he will enlighten this about this molecules, about this study and future aspect. So over to Dr. Mukesh. Is Dr. Mukesh is there?
Yeah, yes, sir. Yes, sir.
Okay,
Yeah.
okay. Fine.
1 minute, sir. I will share my slides. My slides are visible now, sir.
Yeah. It's visible and audible. So
Thanks, sir, for giving me this opportunity. My topic is PHESGO, that is combination of pertuzumab with trastuzumab, EGGO, PHESGO. And as we know that this transforms the journey of your HER2 positive breast cancers. And Project with Herceptin has transformed the treatment landscape and is currently standard of care for patients with HER2 positive breast cancer, either in the neoadjuvant setting or adjuvant setting or in metastatic first line setting. And as we know that in Neosphere study in the neoadjuvant shows that if we add pertuzumab, there is improvement in pathological CR from 31 to 49%. And if we add in adjuvant setting, especially in not positive early breast cancer, and pertuzumab especially reduce the risk of recurrence by 28% as compared to Herceptin with chemotherapy. And especially as we know that in metastatic setting, this Cleopatra study shows that addition of pertuzumab with trastuzumab plus chemotherapy is significantly improve the overall survival. And currently, pertuzumab-based therapy is standard of care in all patients of HER2 positive breast cancer. And this is current standard of care as we know, the patient have tumor more than or equal to 2 centimeter or not positive, we consider neoadjuvant pertuzumab, trastuzumab chemotherapy based 4 to 6 cycles. Then surgery, the patient achieved PCR. Then pertu with trastuzumab based adjuvant regimen for up to 18 cycles. And if patient have residual invasive disease, then we shift to TDM1 for 14 cycles. And if patients have clinically T1 or N0, then directly go for surgery. And if patient is not positive, then pertuzumab with trastuzumab based regimen. And if patient is pathological N0, then Pacli with trastuzumab 18 cycles. So what we facing that IV infusion of pertuzumab and trastuzumab is well established, but we can show that present challenge to patients and healthcare systems because of long infusion time with observation times between infusion, and because of very congestion at various clinics and hospitals, and challenge of improving resource utilization, and especially placement and maintenance of indwelling venous access at various centers, and challenges of venous access in some patients. So this drug, Phesgo by Roche, is the first formulation in oncology to combine the two monoclonal antibodies, pertuzumab and trastuzumab, in one vial for subcutaneous injections. Because these contain the same antibodies as approved for IV pertu and trastuzumab, but is a different route of administration. And it is formulated with recombinant human hyaluronate. So this allows subcutaneous administration of higher drug volumes. Loading dose is 15 ml and then 10 ml is maintenance dose. And it is ready to use fixed dose combination administered by a subcutaneous injection in the thigh over approximately 5 to 10 minutes. And as we know that mechanism of pertuzumab and trastuzumab, we already know. So what does hyaluronate is that? It is endoglycosidase used to increase dispersion and absorption of co-administered drugs when administered subcutaneously, because it allows subcutaneous delivery of larger drug volume. It increases permeability of the subcutaneous tissue by depolymerizing hyaluronate based on preclinical studies. And we know the effects of hyaluronate are reversible, and it reverses within 24 to 48 hours. So as we know that subcutaneous layer in skin contains a matrix of hyaluronate fibers and collagen fibers, which limits subcutaneous administration of volumes to less than 1 ml. And addition of the hyaluronate temporarily and locally degrades hyaluronate at subcutaneous tissue at the injection site with no change in the structure, and providing macromolecules, collagen and elastin. The degradation of the hyaluronate results in temporarily increase in the local subcu administration dispersion area, enabling larger volume of fluids to be administered. And this this slide shows that bolus injection of 10 ml 10% IgG solution without hyaluronate before infusion, and immediately post infusion we see that development of indurations which can be persist for longer times. But if we use hyaluronate, then before infusion and after infusion there is no indurations, no other reaction. So what is the what does Phesgo have the same pharmacokinetic efficacy and safety as compared to IV pertuzumab and trastuzumab? And we show that this study BO30185 phase 1b study shows that pharmacokinetic and efficacy is and safety profile is similar to IV formulations, and the recommended dose is loading dose is 1200 per 2 with 600 tras, and maintenance dose is 600 per 2 with 600 trastuzumab. And this study, that is dose finding study B030185, and they show that loading dose of 1200 mg pertuzumab subcutaneous and a maintenance dose of 600 mg to be used in phase go. And there is no new safety signals observed for pertuzumab sub-Q alone or when co-mixed or co-formulated with Herceptin subcutaneous. And the pharmacokinetic and safety results of this study supported further development of phase go. And this is another study, Federica, phase 3 non-inferiority study, and that assessed the pharmacokinetic efficacy and safety of phase go versus IV pertu and trastuzumab. And this shows that this phase go is non-inferior to IV formulations. And pharmacokinetic parameters are reported for understanding bioequivalence between IV and sub-Q formulations. And we saw that TRP concentration is equal over the times between IV and sub-Q formulations. And this shows that phase go was non-inferior to IV formulation based on cycle 7 and pertuzumab and Herceptin serum TRP concentrations. And this shows that both have same concentration in serum after sometimes. And also this phase go is almost identical total pathological CR rates as compared to IV formulations. And especially if we go for by BMI, so in underweight patients, there is more pathological CR rates by IV formulation. And if we coming to safety profile of phase go as compared to IV formulation, and they show that rate of treatment discontinuations due to adverse events are similar in both arms, and there is no major adverse events is associated with phase go, and increased incidence of adverse events were consistent with other studies that included IV forms, and major side effect is both in IV and phase go is diarrhea or infusion reactions. And we saw that non-inferiority of phase go with conventional pertuzumab with trastuzumab IV according to serum TRP concentration, according to total pathological CR rates, according to safety profiles. So we all patients prefer phase go as compared to IV. This study, phase 2 study, and they assessed that patient preferences for phase go as compared to IV formulations. Because of more than 90% of patients favor the phase go as compared to IV formulation because of less time in clinic, more comfortable during administration, and 87% choose phase go to continue treatment. And treatment had no impact on patients and healthcare physicians speaking times. Most patients had more than enough time to talk to their healthcare physician during treatment with phase go. So what is the time difference between administration of IV and phase go? As we know, usually in preparation, IV formulation usually take 15 to 20 minutes, but in subcutaneous form, maximum 5 minutes. In treatment room, because of various observation times, IV form usually takes 300 minutes, up to 300 minutes, and sub-Q form only up to 50 minutes. So 88% of healthcare physicians thought that sub-Q was the quickest from start of preparation to completion of administration. And they felt that sub-Q required less resource utilization for preparation and administration. And they also agreed or strongly agreed that ready to use sub-Q resulted in less drug wastage. So main reasons for sub-Q preference: less time in clinic, more comfortable during administration, more patients are very satisfied with sub-Q form. Most patients indicated that treatment had no impact on the amount of time they had to talk their nurse or doctor, and that while receiving treatment they had more than enough time to talk to their nurse and doctor. Healthcare physician also indicated that sub-Q had marked time saving and required fewer resources compared to IV formulations. In coming to the safety, generally sub-Q form is well tolerated with a safety profile in line with previous studies using IV form. No new safety signals were observed, including when switching from IV to sub-Q or vice versa. And safety results support that sub-Q in the Tdxt study also with IV formulation. So what are the practical considerations during phase go administration? Ask the patient to sit back in reclining chair or bed and make the thigh area accessible. Be sure to arrange your chair at the right level so that feet are flat on the floor and you are able to sit up straight without twisting, bending or reaching to administer the injection. The injection side should be alternated between the right and left thigh only. It is never administered in the abdomen. Do not split the dose between two syringes or between the two sites of administration. Each new injection should be given at least 2.5 centimeters from the previous site. Choose an area of healthy skin that is not red, bruised, tender or hard. Record the use site to the patient's notes. Inject and maintain the needle at an angle of about 30 degrees. If at any point during the injection the patient feels pain or discomfort, ease of the injection before continuing. Keep the needle in place and check the make sure that the needle is the right 30-degree angle of injection. Make sure that the medication to treat reaction as well as emergency equipment is available for immediate use. After the loading dose, the patient should be observed at least for 30 minutes and after maintenance dose only for 15 minutes. If the drug is administered in the chemotherapy daycare, curtains or other shades are required to ensure. So this drug is preferred by patients and all healthcare physicians in worldwide because of similar safety profile, similar pharmacokinetics, and all other are which comparable to IV formulations. So in coming to the conclusions, phase go is the only first formulations in oncology to combine two monoclonal antibodies HER2 with Herceptin in one vial for sub-Q injection and offer a faster and less invasive method of administration compared to HER2 with Herceptin IV formulation. And phase go at the cycle 7 had same HER2 and Herceptin serum TRP concentrations and incidence of adverse events compared to those seen with IV formulation. Total pathological CR rate also almost identical. Majority of patients preferred phase go. Majority of healthcare physician also preferred phase go. So phase go is now FDA and EMA approved for the same indications for HER2 positive early breast or metastatic breast cancer with or without concomitant IV chemotherapy. Thank you.
Yeah. Thank you, Mukesh. Mukesh described overall all aspect of this phase go. I think in as I have read and I have studied, so this is the subcutaneous preparations. The Roche have launched the combination of this trastuzumab as well as pertuzumab, and I think it is better in terms of IV. It is similar efficacy as well as the ease of administrations and cost saving. I think in each and every aspect, this molecule is identical to this IV preparations. So thank you, Dr. Mukesh. Is there any query from any audience? So Mukesh, have you used this molecule in your clinical practice and SMS or in anywhere? So have
Yes.
you?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
So is there any difference between this IV preparation or subcutaneous preparations?
No, so there is no difference because this is easy to administer for patients, especially the patient want to early discharge during chemotherapy administration. They do not want IV formulations. Many patients are happy with sub-Q formulations.
Is there any administration related precautions or is there administration related stress in your minds whether it is adequately administered or not? So that in my mind, every time the stress of this administration method for this molecule, costly molecule. So is there any stress in your mind?
No, sir. Because sub-Q is less chance of adverse reactions, infusion reactions. So I never hesitate to give a sub-Q formulation.
Okay. So you are comfortable?
Yes, sir. Yes, sir.
Because I am afraid, I am slightly stressed whether this molecule is given or not. So thank you, Dr. Mukesh, for this wonderful talk.
Sir, I have
So-
one question.
Yeah.
So nice talk, Dr. Mukesh. So I have this one question, like for someone having a weight of around 100 or 120 kilos. So do you think this dose is sufficient because it's fixed combination compared to the IV one, which is per kilo based? So what is your comment on this?
So because this dose finding study does not included all patients of underweight or overweight patient, obese, underweight, all patient included, and they shows that this they included various doses like 400, 600, and they show that this dose is sufficient for all patients.
Okay, so you think that that is enough for all weights of patients, right?
Yes.
Okay, thank you.
So
can I have a comment?
yeah. Dr.
Yeah.
Ankur.
Yeah.
I had experience with one patient. Actually, the patient got scared because we have to give this injection for 5 to 8 minutes, and to put the patient in that position and keep the injection just there. The patient got scared that you have given me this injection, I will not take next time. She blatantly refused to take that injection. She said, "Give me IV. I will not take this kind of injection. You will put the injection for 5 minutes." It's very uncomfortable for me.
Okay. So you have put on this this patient on the IV formulation?
Yeah, now I switched to IV. The
Okay.
patient refused that I will not take this injection.
Okay. So just patient wants this IV
Oh.
formulation. I think afraid
Maybe,
for this
some-
continuous administration.
Yes, sir. Or some patients, because in these studies also, only 90% patients are prepared to use sub-Q form. 10% patients refuse to take sub-Q form.
So thank you, Dr. Mukesh, for this talk. And for this, in this second part, that is the Zydus sponsored session. For this, I invite this Dr. Ankur Punia, who is the assistant professor in Department of Medical Oncology at the Mahatma Gandhi Medical College, and he is my best friend. And so he will he will speak on this topic, the TDM, where does it stand in 2022. So I think before the launch of this molecule by the Zydus, it is available in the Roche, and nowadays a generic formulation is available. So he will enlighten us about this TDM1, where does it stand in 2022. So over to Dr. Ankur.
Yeah, thank you, Dr. Desh, giving me this opportunity. So today my topic is to discuss regarding TDM1, what's its role in today's era. So basically, I'm going to discuss what kind of therapies and focusing on TDM1, its role in early and metastatic breast cancer. So now we have a lot of HER2 targeted therapies. Recently with trastuzumab deruxtecan, we have basket has grown immensely, but we don't have that drug. Might have a drug in 1 or 2 years. But now we have so many drugs like pertuzumab, trastuzumab, margetuximab, other ADC which was approved, and oral TKIs like neratinib, tucatinib, lapatinib, and more new TKIs are also coming. So it's getting a very interesting field in HER2 positive breast cancer. So what is basically TDM1? TDM1 is an antibody drug conjugate. So there is an antibody which is trastuzumab, which is linked to a drug mitensin, which is a microtubule destabilizing agent, and its linker is MCC. So how does it work? Basically, it has all the properties of trastuzumab as well as this chemotherapeutic drug. The drug is delivered directly to the cell, and it inhibits the downstream signaling, as well as there is a prevention of P95 HER2 formation, which is one of the most common resistance mechanism, as well as also there is antibody dependent further, and this stable linker helps to prevent a premature release of this DM1 and causes less toxicities compared to just chemotherapy. So as we said, that TDM1 is internalized by endocytosis and it inhibits the microtubule assembly. Mechanism of action is by multiple methods. It directly inhibits HER2. There is an antibody-dependent cytotoxicity, and by endocytosis, it causes microtubular depolymerization. So it causes multiple hits to the cell. So it probably leads to better efficacy because of that. So now TDM1, now we know that it's approved in early breast cancer, which was approved in 2019, and as well as metastatic breast cancer, in which it's approved from 2013. And last year also we got a biosimilar with us, which has greatly improved our understanding and use of this drug. So first, discussing in the early breast cancer, we all might be knowing about this. The most common trial which is now talked about is Catherine, and second is the attempt trial. So Catherine trial, patient who has received neoadjuvant therapy and didn't have a PET CR. In those patients, they were randomized between TDM1 and trastuzumab. And as we can see, invasive disease-free survival benefit of almost 11% was there at 5 years. And we can see the distant recurrence, local lesional recurrence, all were lower in the TDM1 arm. So it's a significant difference for this population, as we know that not achieving a PET CR is considered a poor prognostic marker. And the benefit of TDM1 was irrespective whether patient received just trastuzumab or a trastuzumab-pertuzumab combination, because the difference was around 11% in both the subgroups, irrespective what kind of therapy they received in the neoadjuvant setting. Now, looking at this, we can see that almost all the categories benefited from the TDM1, whether the patient was hormone positive, hormone negative, whatever kind of neoadjuvant therapy they received, whether the patient was node negative, node positive. So all the patients, irrespective of the therapy and the hormone status, benefited from giving this TDM1 in the adjuvant setting. In the long-term 5-year survival, we can see the distant recurrence was reduced by almost 7%. Overall survival, though not statistically significant, but the OS has still not reached, final analysis is still awaited, but it's looking at this very good result. So we hope that OS might also be improved. So this is a second study, it's an attempt study in which they have compared TDM1 versus trastuzumab with paclitaxel followed by just trastuzumab in very early breast cancer, stage 1, less than 2 centimeter node negative breast cancer. So in this we can see that almost this was equivalent results were there. 3-year DFS was very good at 97.7%, and the arm result in both the arms were almost similar. So, and if we compare the toxicities, neuropathy, though it was slightly higher in the TDM1 because we are giving more cycles of this chemotherapeutic agents in TDM1, but infusion related reactions and neutropenia, those side effects were lesser in the TDM1 arm. So it's a good option for patients with a very early breast cancer, as this has been shown in this NCCN guidelines as well. Patient who doesn't achieve a PET CR, it is a category 1 recommendation that we should switch to TDM1. And for patients with early breast cancer, also we can consider just adjuvant TDM1 instead of trastuzumab and taxane. So this is more of that same guideline. We give neoadjuvant, no PET CR. It's a good option to switch to TDM1 because of the better IDFS benefit till now, lower recurrences, and hopefully better OS in the future. So now coming to the metastatic setting. Now we have multiple trials in the metastatic setting, like Amelia, Theresa, Camilla and Amelia subset, which is a phase 3B study, and a Marianne in the first line study as well as there are multiple real world studies which shows the benefit of TDM1, particularly in the metastatic breast cancer setting. So looking at all these trials, slides are frozen, I think.
Hello, hello Anji.
Sir, please join the talk, sir. Webinar.
Okay, इसमें मेल में भेजा ना?
Right.
मैं एक सेकंड में लिंक कहाँ भेजा? मेल में या इसमें व्हाट्सएप में?
So please.
So now it's working. Sorry, I don't know what happened. So looking at the Amelia study, which was in the second line setting, in it was TDM1 was compared versus lapatinib and capecitabine, and Theresa study was for beyond second line setting, in which was compared versus as a physician choice of therapy. So if we look in the second line setting, PFS as well as OS was improved with almost a difference of 6 months in the OS and 3 months in the PFS. And you can see the graphs are clearly separated from the start. And adverse events, also looking at that, adverse events, any kind of grade 3 events were were lower in the TDM1 arm compared to lapatinib and capecitabine arm. And looking at the beyond second line study, Theresa study, it again shows that PFS as well as OS was improved from about 7 months in the OS and 3 months in the PFS, which is a clear separation of the graph from the start. So it shows benefit irrespective of the line of treatment, whether the patient received beyond second line, third line, because you can see there were all kind of patients of around 30% of third line, fourth line, and even more than 5 lines of therapy. In a patient subgroup where the patient has a CNS metastasis at baseline, if you look at the exploratory analysis from the Amelia study in the second line, we can clearly see that even the patient with CNS mets, TDM1 prolonged the overall survival compared with LAP and CAP with a clear separation of graph. Secondly, on the right side, this Camellia study, which will show here better, it's phase 3B study in which the patient who didn't have a CNS mets, the PFS was 7.7 months, and patient with CNS mets had a PFS of 5.5 months, slightly lower, but still on the good side. And similarly, the OS was 30 months in patient with no CNS mets, and it was around 19 months in the patient who had CNS mets. And we can see the response rates in cranial, intracranial response. In this Camellia study exploratory analysis, we can see almost 21% patient had a CR or a PR, and overall clinical benefit rate of around 43% was seen. So it was pretty good considering the very predominance of this breast cancer to go to the brain. Now coming to these were the second and third line studies. Now coming to the first line study. This is the Marian study in which they compared trastuzumab with taxane versus TDM1 or TDM1 plus pertuzumab. Although there was not an arm of trastuzumab with pertuzumab, which is now considered standard because it's a study at which time that trial had still not shown the results. And we can see in this study that results in all the arms are almost similar, whether we gave trastuzumab, taxane, or TDM1, TDM pertuzumab, PFS and OS were more or less same. But if you look at the side effects, again, the grade 3 side effects was much more lower in the TDM1 arm, like neutropenia, febrile neutropenia, diarrhea, or neurotoxicity was lower. So it might be considered a good option in first line as well, though it's not approved. But looking at the results, which shows almost similar to a combination of trastuzumab, pertuzumab, which is now considered standard, we can use TDM1 as well. So in nutshell, if you look at all the studies like Amelia, Theresa, Camellia, and even these new real-world studies from Portugal, Italy, US, and Spain, which shows a good PFS of around 7 to 10 months, which is same as those seen in trials, and a good 2-year survival rate, which is almost similar to what has shown in the trials. So it's not just that it's shown a good result in randomized trial, but we have good real-world studies also which shown the benefit of using TDM1. So now how the HER2 landscape has changed. Now we considered pertuzumab, trastuzumab, and taxane combination in the first line setting. When the patient progresses, we use TDM1, and now we will use trastuzumab deruxtecan whether it's available, but we don't know when. But still, then TDM1 is a very good option. And now we have multiple options beyond TDM1, but we can use like tucatinib combination, naratinib, margetuximab, and multiple more new drugs also are coming. So this is an Indian experience of using this molecule in 80 odd patients. Almost 50% were de novo metastatic and 50% were recurrent or recurrent cases. All kind of metastases were there, brain mets in around 30% of patients. And you can see the CR rate of almost 10% and a PR of 45%. Overall clinical benefit rate was almost 70%. The PFS seen was 10 months and overall survival of 28 months, which is almost similar to the randomized studies. So it shows that it's beneficial to use in our patient population as well, with not that many side effects, which are grade 3-4 side effects were seen in only around 25% of patients. And the hormone status and the prior any kind of HER2 therapy didn't change the kind of response. So it again shows in a real world setting in India that TDM1 has shown very good results. The problem with TDM1, around a year back, that it was very expensive. We didn't have it, and we were not able to give to it. Was most of the patients, only very few patients were able to afford it. But as we now know that a first TDM1 biosimilar was approved, and it is available to us for more than a year now. So this was a study in Breast Cancer Journal which was published, which was a comparison of this Ujvira efficacy, safety, pharmacokinetic immunogenicity versus the innovator TDM1, which clearly shows that the result demonstrated that it was similar in efficacy, safety, and all other parameters. So eventually we got this molecule, And I think with this molecule, it might be more beneficial to patients, because as more and more patients will able to afford to take it, in the second line and third line setting, because uh, definitely has a remarkable improvement for these patients, and particularly 5 to 10% have a very long-term outcome with the use of this drug. Thank you.
Thank you, Dr. Ankur. From my two queries. So the first query regarding this Catherine data. Are you convinced with this Catherine data, and are you using this drug in adjuvant setting after the PATH-CR was not achieved? So are you convinced, and are you using this drug in adjuvant settings?
Yes, sir. I think that the difference of 11% is very, very good in a early breast cancer setting. That difference, that is a remarkable difference for this use of this change of this drug. So I recommend to patients who can take this drug, you should try to take this drug.
So I am also convinced. So I am using within 3 or 4 patients for this adjuvant settings. But second part in this metastatic setting, are you convinced in first line without trastuzumab and any chemotherapy? Are you using in first line TDM1 in de novo metastatic HER2 positive breast cancer? Are you convinced single agent that TDM1 you are not using this chemotherapy, and you are not using trastuzumab?
Though the data is convincing, but I have not personally used it. Again, the same point was that it was an expensive molecule, and then we have a superior, which has been proven. So I was using trastuzumab, pertuzumab, but now with the availability of TDM1, I have recommended to 1 or 2 patients in the first line who cannot afford, pertuzumab, because it's very expensive. So I've seen in 1 or 2 patients good results in first line settings.
So second query, if you are using the trastuzumab or any chemotherapy combination in metastatic setting first line, so where does you stand for this TDM1 in second line or third line or fourth line? So this molecule where stand? So the lapatinib, capecitabine, or this TDM1. So are you using this TDM1 in third or fourth line, or are you preferably to use in second line?
No, I prefer to use in second line, because it has shown better result irrespective. We see that CNS, even in CNS Mets, which is one of the most common, site of progression, even in those patients, it has shown good results. So I definitely prefer to use it. Then again, it sometimes comes to the patient preference, because lapatinib, capecitabine is an oral combination, easy to take. That's all depend on patient preference. But my preference is to give TDM1, if not taken earlier, to give in second line.
So you are putting in second line sequencing if you are using initially trastuzumab. So is there any query from our other audience part? So I think very well presented the wonderful talk by this Dr. Ankur, and I think he solved my query and my question in my mind. So thank you, Dr. Ankur. And so further sessions for this today topic is this management of hormone receptor positive HER2 negative breast cancer. So for this optimal use of CDK4 or 6 inhibitors for HR positive or HER2 negative, I invite Dr. Srujna Joga. She is consultant medical oncology at Rajiv Gandhi Cancer Research Institute, Delhi. Thank you, Dr. Srujna, for my invitations, and I will hand it over you for the topic. Is there any?
Yes, sir. I'm trying to share my screen.
Yeah.
Are you able to see my screen, sir?
Yeah. Fine.
Yes, ma'am. Just make it full screen.
Yeah. Is it now in the slide mode?
No, ma'am.
Not yet. Are the slides moving?
No.
No.
Ma'am, can we share your slides from our end?
Just let me give you one more try.
Okay, sure.
So is it visible now?
नो मैम एक बार इसे क्लोज करके ना
हम्म
पीपीटी स्लाइड को बंद करिए एक बार, ठीक है, देन एक बार ओपन कर लीजिए उसको स्क्रीन स्लाइड मोड पे डाल के, देन उसको शेयर कीजिए।
तो स्लाइड मोड में डाल के शेयर करना है।
जी,
तो
पर पहले उसको क्लोज करना, उसके बाद उसको ओपन करो।
now it is visible.
Yeah, your slides are visible, but not in a slideshow mode. Ma'am, can you move your slides?
Yes, I am moving.
No, it's not moving, ma'am.
Okay.
Ma'am,
आपकी तरफ से आप शेयर कर सकते हो?
yes, yes, yes. Ankit, please share the slide.
Okay, मैं stop share.
Yeah.
Okay.
Ma'am, is
Good
the
evening,
slide,
Paloma.
okay, ma'am. You can start.
Yes, sir. I would like to thank Dr. Tdxt Goyal sir for giving me this opportunity. So I would be speaking about optimizing the use of CDK4/6 inhibitors in the hormone-positive breast cancer metastatic setting. Next slide, please. Next slide. So around 30% of women who present in early breast cancer stages will eventually develop metastatic disease sooner or later. And upfront metastatic disease is seen in only 6 to 10% of patients in our regular clinical practice. And out of these, hormone positive patients are 60%, and the rest constitute the 40% of the patients. Next slide, please. So the hormone positive metastatic breast cancer spectrum varies from a very indolent course to as patients having a very long disease-free interval. They present after 5 to 10 years of completion of adjuvant treatment. And they usually present with bone-only mets or some very minimal amount of visceral disease. These are usually sensitive to the endocrine therapy. On the other hand, we have a very virulent disease which presents immediately after completion of adjuvant therapy to around 3 to 6 months. Patient develop frank metastasis from bone to the extensive visceral disease and a shorter disease-free interval, which we classify as endocrine resistance cases of hormone-positive breast cancer. Next slide, please. So what exactly are the endocrine resistance means? So as per the ABC guidelines given by the ESMO, the primary endocrine resistance, it's defined in the adjuvant setting as well as in the metastatic setting. In the adjuvant setting, if the patient is on endocrine therapy within the first 2 years while on treatment, if the patient relapses, or if after completion of adjuvant therapy, if the patient relapses within 12 months, or if the patient has progressed within first 6 months of treatment of upfront metastatic breast cancer while on the endocrine therapy, this is classified as primary endocrine resistance. Whereas the other opposite side is the secondary endocrine resistance. And there is the other term which we frequently use where the patient is in visceral crisis or not. So the definition goes like this, that it's the signs and symptoms of organ dysfunction, and it not only the signs, it also if there are laboratory abnormalities or if there is rapid progression of the disease clinically. So it is not the mere presence of visceral mets which is called visceral crisis. These all parameters, that is the clinical signs and symptoms, laboratory studies, and the very rapid progression of the disease. For example, if the patient, to say a patient is in lung visceral crisis, the patient should be having rapidly filling pleural effusion, which is causing the breathlessness and even grade 4 dyspnea. Or if the patient is having liver visceral crisis, the abnormalities in the bilirubin and the along with the elevation in the liver enzymes together constitutes the liver visceral crisis. Next slide, please. So those are the definitions theoretically. So what happens exactly inside the cell when we go into the biochemical pathways, the mechanism for the endocrine resistance? To understand that, the normal physiology should be understood. So the estrogens which enters a cell binds to the cell membrane, enters to the cytoplasm, and thereafter binds to the enters the nucleus and binds to the estrogen receptor there. There the transcription of the target gene occurs, and estrogen receptor action, the proliferative action takes place. So at every step, we usually target the hormones using the aromatase inhibitors or the tamoxifen, which is a selective estrogen receptor modulator, and the fulvestrant, which is a estrogen receptor downregulator. So the endocrine resistance develops in the alternate pathways. So the cell turns to the other pathways for its resistance mechanisms. So one of the main thing is the alteration in the cell survival and cell cycle pathways, which occurs inside the nucleus, that is the DNA, which is the cyclin D1 amplification. And the second pathway is the activation of the growth factor pathways. The most familiar one is the RAS-RAF-MEK pathway. But here in the hormone positive breast cancers, PI3K pathway is more actively involved because the P3K mutation occurs. And there is also deregulation of the estrogen receptor pathway itself. The estrogen receptor present in the nucleus gets deranged because of the development of mutations in the ESR1 gene. Next slide, please. And one of the most common things, there is a cyclin D1 amplification. So to see that for the cell to undergo the G0 to G1, G1 to S transition, the main regulating factor is the retinoblastoma gene. So the retinoblastoma gene is usually inactivated when it is not phosphorylated because E2F factor binds to the RB gene and it is in inactive form. When the RB gene phosphorylates, the E2F factor is released and the cell cycle is initiated from G1 to the S phase. At this point, next slide, next. At this point, the cyclin D, when it binds to the CDK4/6, which is a cyclin-dependent kinase 4/6, this will cause inactivation of the RB gene and release of the E2F. So here we are targeting the CDK4/6 inhibitor so that this pathway will not be activated and the E2F will not be released, and hence the cell cycle will not progress. Indirectly, it will be arrested, which is called the cell cycle arrest, which is the typical mechanism of action of this CDK4/6 inhibitors. Next slide, please. So the three drugs, the palbociclib, abemaciclib, and the ribociclib, are the three CDK4/6 inhibitors which have come way after 2015. So they have been tried in the first line and the second line settings. In the first line, the partner endocrine therapy is the letrozole, for which Paloma 2, Mona Lisa 2, Monarch 3, and Mona Lisa 7 trials are available. Mona Lisa 7 is done in especially in peri and premenopausal patients, whereas the other three are done in the postmenopausal setting. Coming to the second line therapy, we have Paloma 3 and Monarch 2 trials, where the partner endocrine therapy is fulvestrant along with the CDK4 inhibitor. And the Mona Lisa 3 trial included both the first and second line settings patients, and the drug used is ribociclib along with the fulvestrant. Here, when we concentrate the slides on the red bar, the first line setting, palbo, ribo, or abemaciclibs have done fairly, have the same median PFS to the around 27 months, whereas the OS difference was starkly high in the Mona Lisa 2 arm, that is a 63 months versus 51 months. And the hazard ratio is also quite remarkable, 0.76, that is 24% cases of death reductions when this drug is used in the metastatic setting, which we have never heard of in the metastatic breast cancer setting. Till now, we had a PFS data only. Next slide. So giving an overview of the three trials, they had showed a median PFS of 24 months across all settings and the hazard ratio of 0.5. Next slide. But the difference occurred in the overall survival, whereas the palbo and the abemaciclib failed to show any OS benefit. Here, the Mona Lisa 2 is phase 3 trial in the perimenopausal women, has shown that the overall survival has improved significantly to the tune of 63 versus 51 months. Next slide, please. And the time to first subsequent chemotherapy has also been delayed by almost 1 year. Next slide, please. And the other setting, the phase 3 Mona Lisa 7 trial done in ribociclib plus endocrine therapy in the premenopausal setting. It has also shown the PFS benefit of 23 versus 13 months. Almost 10 months of progression-free survival difference is seen in this setting. Next slide, please. And the updated, it continued to show the OS benefit after prolonged follow-up. That is 24% relative reduction in death is seen, and the median OS 58 versus 48 months. Next slide, please. So once the patient is put on the upfront metastatic setting, we start hormonal therapy, CDK4/6 inhibitors along with this one, along with the aromatase inhibitor or the tamoxifen if premenopausal. Then ultimately the patient will develop estrogen receptor mutations. So how frequently it is seen? Is mostly seen in the metastatic breast cancer patients to the tune of 25 to 40% of patients having ESR mutation, as evidenced in Paloma 3 and Bolera 2 and Sophia trials. Next slide, please. So in this setting, the Mona Lisa 3 has taken both the patients upfront as well as patients who progressed on the first line. The ribociclib fulvestrant was given in these patients, and in these patients, the primary endpoint was PFS. This has to be noted, and the secondary endpoints were overall survival, because the drugs have shown the PFS benefit across all the CDK4/6 inhibitors, but the OS benefit is only seen with the ribociclib. At the end of 5 years, 56% patients were alive as compared to 42% in those with only fulvestrant. Next slide, please. So why are these there differences? Because the CDK4/6 inhibitors, the molecules are the same, even though the company manufactured is different, whether there is any difference in the pharmacokinetics or dynamics. But when we see across the trials, the disease-free interval, the population which they took initially, the endocrine resistant population, that is whose DFI is less than 12 months, is very less. In the Mona Lisa 3 and 7 trials, it's around just 5-7% patients. Whereas in the Paloma 2, Mona Lisa 2, Paloma 2 trial with palbociclib, there is only around 22% patients had endocrine resistance disease. So, so the Paloma 1 and 2, there was a combined subgroup analysis, which is an exploratory analysis. So this is to be taken with caution. In patients who had a disease-free interval more than 12 months, that is, who are endocrine sensitive, there is an OS benefit of 64 versus 44 months with a hazard ratio of 0.73. Next slide, please. So, so till now we are talking about palbociclib letrozole in the first line setting, and there is the other trial of palbociclib, ribociclib and fulvestrant in the first line. So whether to give fulvestrant in the first line setting as compared to the letrozole, do the outcomes differ? So the Parsifal trial was done, but it failed to show any improvement in the progression-free survival. It remained the same, 32 versus 27 months. Next slide, please. In the second line therapy, when the patient progressed on one line, 1 or 2 lines, then the patient was put on fulvestrant with the CDK4/6 inhibitors. Next slide, please. So the Paloma 3 trial did not show any improved, even though it is numerically significant, 34 versus 28, but it was not statistically significant. Again, they divided into endocrine sensitive and endocrine resistant population. They observed that patients who are endocrine sensitive had an OS benefit as compared to that of those with endocrine resistance. Next slide, please. Whereas with the Mona 2, that is the abemaciclib, it is the opposite. It showed a 9.4 month OS benefit, especially in patients with primary endocrine resistance. That is 38 months versus 31 months, as compared to those with secondary resistance, which is around 40 months. Next slide, please. Again, previously discussed slide, the Mona Lisa 3, ribociclib plus fulvestrant showed a significant improvement in overall survival. Next slide, please. So this is all about clinical trial data. Do we have a real world evidence? We have in Indian setting at our own institute done by Dr. Chaturbhuj and Dr. DC Dogal sir and team. They collected data from RGCA and the BLK hospital. It was a retrospective study done in around 180 patients, including who have received both palbociclib with fulvestrant as well as with aromatase inhibitor. And both premenopausal and postmenopausal were taken into account. Most of the patients were premenopausal. Next slide, please. The median PFS when CDK4 inhibitor was used in first line is 20 months, as seen in the other trials, which was 25 months. And the median PFS in the second line is 12 months. And the response rates were 80%. And there was no much toxicity observed. It was the same as seen in the trials. 10% patients had grade 3 to 4 events, and most of them had neutropenias. Next slide, please. A similar study done in the South India, multicentric study, including 5 centers, with 133 patients over the span of 4 years, a retrospective analysis, and with 60% patients were in the first line setting and 40% were in the second line. Next slide, please. Here, the median PFS in the first line setting was to the tune around 20 to 20 months, with bone-only mets having higher PFS, as we know. And the PFS second line is around 14 months. And the most common side effect was neutropenia. Next slide, please. And the newer trials are addressing the use of CDK4 inhibitors with the oral selective estrogen receptor deregulators, because patient will be having a hard time getting this fulvestrant 2 injections in each buttock. So the oral SERDs are in development in combination with the palbociclib. Next slide, please. So like in colorectal cancer, where we have data for bevacizumab, using bevacizumab beyond progression, or in ovarian cancer using bevacizumab beyond progression. Do we have data for continuation of this CDK4/6 inhibitors in the beyond progression? Because most of the patients will be having this patient assistance program where they get 9 months of the drug and the rest will be free. So they usually don't want to lose that drug. And so this was answered in the latest abstract presented in ASCO 2022, the phase 2 maintain trial. Next slide, please. So the ribociclib was continued beyond progression along with the endocrine therapy, which was switched, or it was only the endocrine therapy. If the patient was on AI, he was put on fulvestrant. If a patient progressed on fulvestrant, exemestane was allowed. This protocol was amended later. So the primary endpoint was PFS in this setting, and secondary endpoints were overall response rate, clinical benefit rate, and ctDNAs were also taken. Next slide, please. So the median progression-free survival with the patients who were continued on the CDK4/6 inhibitors was 5 months as compared to 2 months with patients who are on single endocrine therapy. And the hazard ratio is 0.57. Next slide, please. So there are the other molecules like palbociclib and abemaciclib are in line addressing the same question, whether to continue this drug. These are still in phase 2 and phase 2 trials. Next slide, please. The other question comes when the patient is on CDK4/6 inhibitor and AI therapy. Once on progression, if he is PIK3 mutant, which is the most common mutation, we would like him to put on alpelisib with fulvestrant according to the SOLAR-1 trial. But in that trial, only 5 to 6% patients were on CDK4/6 inhibitors prior. So this question was taken further, and a BILEAD trial was done, in which 3 cohorts were taken. Patients who were on CDK4/6 inhibitor with AI were switched to, were allotted to alpelisib and fulvestrant arm, that is the cohort A. And the patients who were prior on fulvestrant and CDK4/6 inhibitor were allotted to alpelisib and letrozole arm. And the cohort C, the patients who were...
Sorry to interrupt, ma'am, but kindly conclude your talk, ma'am.
Okay. So it was observed that patients who have received alpelisib plus fulvestrant, the median PFS was 7 months. Only those patients who received fulvestrant in the second line along with alpelisib had a benefit, and there is no benefit in patients who were switched from fulvestrant to letrozole, with the partner being alpelisib. Whether single agent endocrine therapy or alpelisib did not matter much. Next slide, please. So the Young Pearl trial addressed whether the capecitabine, that is the chemotherapy, or the hormonal therapy is better in patients who are premenopausal, who are likely to have a bad prognosis. Next slide, please. So it showed that there was still the hormonal therapy favored in young patients also. That's the Young Pearl trial, 20 months versus 14 months. Next slide, please. And the pharmacokinetics and pharmacodynamics almost remain the same, except for the abemaciclib dosing, which is twice a day, and which is to be given continuously. And the palo and ribo were given 3 weeks on and 1 week off. Next slide, please. And the key adverse events, as we all know, the class effect of ribociclib is QT prolongation and liver toxicities. And with abemaciclib, it is diarrhea predominantly and the venous thromboembolism. Neutropenia is a class side effect of all the CDK4/6 inhibitors. Next slide, please. So there are multiple resistance mechanisms. They can be de novo resistance who have progressed on 3 months. It could be due to RB1 loss. And there may be acquired resistance also due to the development of other mutations. Next slide, please. So the in patients who with hormone positive metastatic breast cancer who are in visceral crisis, we usually start with chemotherapy. And even in patients who have a very short DFI and with a visceral predominant disease, the CDK4/6 inhibitor along with endocrine therapy is still the drug of choice. And in patients who are having de novo metastatic disease and a very good long DFI and oligometastatic, so we can skip CDK4/6 inhibitors in this setting and still put on single hormonal therapy. Next slide, please. So to conclude, CDK4/6 inhibitors should be used in earlier lines, both first and second line, if not used in first, the metastatic breast cancer, because they have got a PFS and OS advantage, especially with the ribociclib data with Mona Lisa 3 and 7. The side effect profiles differ between all these, but still they are very well tolerated as compared to the chemotherapy. And even in patients with visceral disease, the disease control and response rates are similar as compared to the chemo. And a lot of research is going on with the combination therapies with the CDK4/6 inhibitors. Okay, sorry for taking for running out of time. Thank you.
Sir, please unmute yourself, Tdxt sir.
So sorry. Thank you, Dr. Shujna. And so for this talk, and you covered all the aspect of this HR positive metastatic breast cancer about the CDK4 or 6 inhibitors. So we will cover the next practical aspect in this panel discussion. For panel discussion, the keeping the best choice, the CDK4 or 6 inhibitors, I invite Dr. Rajat Bajaj, who is the senior consultant medical oncology in Fortis Hospital, Noida. So he will moderate. And the other panelist is Dr. Sudhir Palsania. He is in the Shelby Hospital, Jaipur. Dr. Sujna is in Rajiv Gandhi Cancer Institute, Delhi. Dr. Trivikram Rao in Hisar American Oncology Institutes. And Dr. Rajiv Saini, he is Sri Mata Vaishno Devi Narayana Super Specialty Hospital, Jammu. Dr. Mukesh Rulania, he is in the SMS Hospital, Jaipur. Dr. K. Medhi in Batra Hospital, Delhi. And Dr. Abhishek Singh, he is in the Lucknow medical oncologist, and Dr. Yogesh Nishchal. So I will invite all panelists, and for this, I will invite Dr. Rajat for moderate this session. Thank you, Dr. Rajat.
Thank you. Good evening. Am I audible to everyone?
Yes. You are audible.
Yeah. Can I have my slides put up?
Just
please?
give me 2 minutes.
Good evening, everyone. Yeah, please. I thank Dr. Goyal and all the organizing team members for having me here. I've been listening to
sorry, just want to interrupt. Dr. Tarachand is also in panel. Sorry, Dr. Rajat. Dr. Tarachand is also panel.
Yeah. Sure.
Yeah. So over to you, Dr. Rajat.
Yeah. So a very nice conglomeration of a lot of important topics which has been done by the organizing team, and I congratulate them for organizing this meeting. And I thank Dr. Srijna for setting the tone for this panel discussion by talking about CDK4/6 inhibitors in a very elaborate and lucid manner. The topic that has been given to me is keeping the best choice CDK4/6 inhibitor in hormone receptor positive, HER2 negative metastatic breast cancer. How do we really tackle our patients in 2022? So next slide, please. So as medical oncologist, I am sure that all the eminent panelists that I have with me, all of them are approximately 9 in number from various parts of India, will surely agree that CDK4/6 inhibitors is the way to go ahead in a patient of hormone receptor positive, HER2 negative metastatic breast cancer if the patient is not in visceral crisis. These are the treatment guidelines, and the recommendations is by all the guidelines, be it NCCN, ESMO, or the ABC guidelines, which do tell us that CDK4/6 inhibitors with the partner drug combination is the most effective therapy nowadays for the treatment of HR positive, HER2 negative metastatic breast cancer. So I will start with Dr. Tarachand, whose name was taken at the last. Dr. Tarachand, good evening. So do you think that there is definitely a role of CDK4/6 inhibitors in your practice? Are you following these guidelines routinely in your practice and prescribing these tablets to your patients?
Yeah, Rajat, I don't think that anybody can deny at this time point the role of CDK4/6 inhibitor in a metastatic breast cancer in hormone receptor positive, HER2 negative. But we have seen the era also that when we were trained that in this subset of disease, when there was only bone mets or the patient was not in visceral crisis, we were using only the hormonal therapy only, without CDK4/6. Now they have entered, and now it is the standard of care, which improving not only the progression-free survival, compliance of the patient, but also the overall survival without
So
much
if you
any
have
side effect and preserving the quality of life.
Yeah, if you have a patient who is a ER 8/8, PR 7/8, HER2 negative, 7 bone lesions, and PS of 0, and the patient comes to you, would you prescribe CDK4/6 inhibitors? Patient is not in visceral crisis, or would you give the option of single agent fulvestrant, single agent aromatase inhibitors?
Yes, this option is always there. But this is in the case of only when the patient is not affording. Otherwise, this is the otherwise CDK4/6 inhibitor just we are offering to the patients.
Okay, right. Dr. Srijna.
Yes, sir. So what is the age of the patient?
So you have, I'm of course telling you everything, but I'm saying that you have set the tone for this panel discussion, so you have to definitely come in and answer this question. The age of the patient is 70 years. She's a fit lady, and cost for her is not an issue. She is a proper patient who comes to RGCI where cost is not an issue. So you tell me that would you like to give CDK4/6 inhibitors to this patient?
Yes, sir. There are both the options. We can give that, or single agent AI or fulvestrant can be given to this.
What would you do? And Dr. Doval is not. Yeah.
If cost is not an issue, I would offer CDK4/6 inhibitor along with the aromatase inhibitor.
Okay, Dr. Rajiv Saini, good evening. Jai Mata Di, please, sir.
Jai Mata Di ji. Rajat, I think if we see the subset analysis also, even the patient who have bone only mets also benefited with the use of CDK4 inhibitor. So only the case scenario where we'll not give CDK4 inhibitor is one is visceral crisis, another is patient cannot afford.
Okay, Dr. Trivikram, are you there?
Yes, sir, I'm here.
Right.
I would definitely recommend.
You will recommend, but then I want to ask you one thing. I have the data from the Falcon study, which tells us that if the patient has got bone-only metastasis, the progression-free survival is equal to what it is for CDK4/6 inhibitor. So why not reserve CDK4/6 inhibitor for the second line and give fulvestrant to this patient in the first line? Can that be the case?
Yes, that can also be done, but my personal choice will always be CDK4 inhibitors.
But why? That's what I want to know. Why? Is there any reason? The PFS is the same. We are not talking about overall survival as of now. So why not a single agent fulvestrant? Anyone? Dr. Sudhir, would you like to give in a bone only metastasis patient? We have a similar PFS from Falcon study and all the CDK4/6 inhibitors. So can fulvestrant single agent be the first line choice? Dr. Sudhir, please.
Yes, sir, but CDK4/6 inhibitors, they are the best in the first line only, and the convenience of the patient also. Fulvestrant is injectable and their oral therapy is available. The CDK4/6 is the best option for the patient.
Okay, Dr. Mukesh.
Sir, I agree that we should use CDK4/6 inhibitor as earlier as possible,
Okay.
and because these are orally patient can be taken and no
Okay.
need to admissions and easy to taken, minimum side effect profile. So I will go for CDK4/6 inhibitor with AI inhibitor.
Okay, Dr. Yogesh. Dr. Yogesh, do you agree? Any change in thoughts?
I am not sure about the Falcon study, how much it was the response rate, because the overall response rate will matter here. And also addition of zoledronate will be helpful with so many bony meds.
Same,
So
response rate same. Response rate same to the extent of 65-70%. But still, would you like to go ahead with CDK4/6?
I mean, both the choices will be there. You will discuss with the patient. And if they are convinced with the data, then obviously we'll go accordingly. But both choices are.
Just to interrupt you, that we are just, I think we are just trying to compare the cross trial comparison only. And the Falcon study was done in the absence of CDK4/6 inhibitors at that time. And at that time, the fulvestrant was better than anastrozole. But now we have the another Paloma 2 and other studies, Paloma 3 and other studies, where the fulvestrant itself is compared with the fulvestrant plus the CDK4/6 inhibitor, where the CDK4/6 inhibitors are taking the lead and procedure against the fulvestrant. So I don't think we can do the many and more study and we can make a vicious cycle that now we just go again with the Falcon study and we will compare with the CDK4/6 inhibitors again, when we already have that the fulvestrant plus CDK4/6 inhibitors are better than the fulvestrant only. And another side, the anastrozole plus that means CDK4/6 inhibitors are better than the that means
so definitely we are doing a cross trial comparison, which we have in any case will have to do, because there is no upfront comparison data. When we talk about CDK4/6 plus fulvestrant, it is mostly in the second line. But then yes, your point well taken. Falcon was 2016, we are talking about 2022. So Dr. Mehdi, sir, what is your take? Any scope for us to not recommend CDK4/6 inhibitors nowadays, or is it for each and every patient who's not in visceral crisis? Mehdi sir.
Yeah, I think now from the clinical trial and from the experience of all of us, the role of CDK4/6 inhibitor is established by now. Although there is no significant difference in PFS in bone-only metastasis, but my choice still is CDK4/6 inhibitor plus aromatase inhibitor in this setting.
Right.
Can I make a comment here? Dr. Abhishek this side from Lucknow.
Please. Oh, sorry, I didn't come to you. Please do that.
I agree with Dr. Tarachan. What he has mentioned that Falcon, when it was started, it was CDK4/6, they were not available. So definitely in that setting, and data are almost similar, but still the OS benefit is more important, which we have just got after the OS analysis of Paloma and Mona Lisa 2 and 3.
We are coming to OS. We are coming to OS, sir. आ रहे हैं. अभी आपके पास आ रहे हैं OS लेके.
In that case, in that scenario, if patient is not having any financial problem and it can be recommended, then the first choice would be CDK4/6 along with AI. That is what I.
Okay, right. Dr. Abhishek, please tell us that if you have your point very well taken. We're talking about survivals also now in 2022 with so many trials telling us about OS data being mature. One of them being, Mona Lisa 2 just 2 months back. So when a patient comes to you, what are the factors that you really put in your mind to decide about which CDK4/6 inhibitor that you need to give? Can I have the next slide, please? Suru, can I have the next slide?
So
Yeah. So we have lot of data. We have 3 CDK4/6 inhibitors. We have the trials in the first line, with the trials in the second line. This is the slide to show that almost all the CDK4/6 inhibitors in first and second line, they have shown an improvement over the comparator arm, and the quantum of improvement also has been almost the same. Of course, there are few differences. Next slide, please. So yeah, this is what I'm talking about. So which one to choose from? So next slide. So all of them, they look similar, isn't it, Dr. Abhishek? So how do you really choose between the 3 ladies or the 3 babies, whatever you can say? And next slide. So talking about factors considered while selecting. So these are the factors, and I want to know from you, which are the factors that you consider while selecting these 3 CDK4/6 inhibitors. You can name any 2 or 3, and then we move ahead.
So first thing, I just want to say that I have more experience of using ribo because of the cost constraint initially, when the data were not very much there. But now if we have if you talk about the menopausal status, we have pre-menopausal data only for the ribociclib Monalisa 7. So looking into the menopausal status, if patient lady is a premenopausal female and we want to use CDK4/6, ribo will be the first choice for me. And comorbidities, if cardiac toxicity is the concerning factor, I would rather avoid giving ribo, rather choose palbo instead. And like that, I mean, there is no bias, but first thing which I consider is the cost factor, of course. Because
cost is not an issue. So this patient is, with the patient that we're discussing, cost is not an issue. We're discussing only signs. So you said age and menopausal status, comorbidities. You already said that survival is also important for you, Dr. Tarachan. So what are the factors that you consider? 3 CDK4/6 inhibitors. Any preferred choice out of the 3 CDK4/6 that you have? And this is everyone has to remember, not
cost also. Sometimes patient preference goes with the what is the cost of all of these 3
cost
because
is not an issue.
there
Cost
are
is not an
20,000
issue.
rupees difference in 3 at each.
So we are
Ribo
not
versus
discussing,
Paloma versus Avema.
we are not discussing cost at all. It is only purely science. So what exactly factors which we consider, and everyone has to remember, number one, cost is not an issue, and number 2, this is not a sponsored session at all. So anyone can have free views on whichever CDK4/6.
Okay. So I don't think any other factor I will consider if the patient is already a stage 4 breast cancer with a hormone.
Okay. Mary sir, I come to you. What are the factors that you consider?
Yes, apart from these 2 factors, age, menopausal status, and comorbidities, I would like to tell you about the site of metastasis. If there is brain metastasis, then I think abemaciclib has the better role. In brain metastasis, my choice is abemaciclib. Otherwise, all whatever has been discussed, so I agree with that. But only this point I would like to highlight.
So if there is no brain metastasis, what is your go-to drug? Whether either it is Palbase or Crixana or Ramivan?
Yeah, in premenopausal, I go with ribociclib, and in postmenopausal, any of the ribociclib or palbociclib. There is no specific difference. Only in presence of little liver dysfunction, there is some difference. Otherwise, only it is from clinical experience. There is no significant difference.
So Dr. Abhishek said his experience is maximum with ribociclib. Dr. Mehdi, your experience is the maximum. So which CDK4/6 inhibitor you have got maximum experience with?
Yeah,
Hello?
my experience, more experience. I have more experience with ribociclib.
Okay. So, Dr. Rajiv Saini, so what do you have to add anything to this? And so there are people who are saying that overall survival also is an important issue. Which are the factors that you consider? Suru, please show us the other factors also.
Okay, Rajat, I think one more factor which we have to take into account is
Go
the
back. Go back. Yeah.
yeah
Please.
is the quantum of hormone positivity, as we have seen that
Hormone full positive, 100%.
no
Yeah.
okay, that is okay. I say if the quantum of hormone positivity is less, around 20-30%,
Yeah.
then abemaciclib can be considered. Or if there is a primary endocrine resistance, then abemaciclib has better role. If patient has a more of liver metastasis or brain metastasis, then abemaciclib can be preferred. Otherwise, or if the patient has some GI already GI disturbances already, then we can avoid abemaciclib. I mean to say, if patient has on the basis of toxicity profile also, we can choose our drug also.
Agree. Toxicity is very important. Of course, we're not talking about financial toxicity here, but otherwise toxicity is important. Side effects, like it is mentioned. So, Dr. Trivikram, is scientific evidence important for you? So, are you still prescribing palbociclib in the era of Crixana having overall survival benefit in both first line and second line? Is Palbase completely out of your clinical practice now?
Yes, earlier it was palbociclib. For me now it is, I'm mostly using ribociclib now.
Are you sure about this? Because you may come in a Pfizer symposium and you again, we can meet there as well.
Rajat,
are you sure about this?
Rajat, Palbase is not not altogether out, because the choice of patient in that trial also differ. Because in this ribociclib trial, they have taken more of the hormone sensitive the primary sensitive disease, while the Paloma trial have taken all the patient, including the secondary resistance or primary resistant tumor also. So there is a difference of patient selection.
Sorry, Dr. Rajat, I think Dr. Sudhir is also there, Dr. Yogesh, and
I'm coming to them.
Their comments on this point.
So, Dr. Sudhir, do you agree that there are people who would say, panelists agree with the fact that overall survival is in favor of Crixana, and most of them seem to tell about Crixana being their preferred choice. But then Dr. Rajiv Seni putting across a very strong point, saying that endocrine sensitivity also and the inclusion criteria does matter. So palbociclib also is no less as compared to Crixana when we are talking about the efficacy of CDK4/6. So what is your take between Crixana and Palbase as far as the scientific evidence is concerned?
Scientific evidence is for both the palbociclib and ribociclib, and there is no statistically significant because there is no head-to-head study or anything in this. And palbociclib is also a good option, but we prefer the ribociclib in this era because there the dosing schedule is better. In the India, this is also a good thing, but otherwise they are it is not that we discard the palbociclib studies at all.
Okay, Dr. Srijana, do you agree that Palbase also stands firm ground even if there is overall survival benefit with Crixana?
Yes, sir. In endocrine sensitive setting and in elderly, I would prefer palbociclib.
Okay, so Dr. Yogesh,
Dr. Rajat, I want to ask, nowadays in few months, the generic palbociclib is available freely available. So cost is coming down. So I think to all panelists, so we are discussing on this ribociclib is better, abemaciclib is better, but you are still in favor of this palbociclib after the introduction of this generic.
Yeah, so definitely, see, they did not talk about this point because I told them that cost is not an issue. But then, of course, with coming in of generics, it is going to be a different ball game altogether, because cost definitely in the OPDs is an issue. We can talk about in webinars, cost not being an issue. So your point is well taken. Dr. Yogesh, would you like to take this question from Dr. Goyal?
Dr. Rajat, one more thing. I just want to ask, what is the experience in visceral mets with the CDK4/6 inhibitors?
We are coming to that.
The bone mets patients are doing extremely good. They are crossing even the PEP limit also, and they are doing. What is the experience of the panelists or you that within patients with the visceral mets, not the crisis, you can say, sometimes you can handle like visceral crisis also. What is the experience?
I'll take quick comments from Dr. Yogesh and then I'll come to this question. Dr. Yogesh, so do you think that in your practice, this overall survival is becoming an issue when you're talking about Crixana? When you're talking about Palbase, there can be patients who can talk about overall survival only being with Crixana, or do you still agree that Palbase and Crixana, they stand their grounds firmly respectively?
I think in the context of real world practice, I think they both stand together.
Okay.
Absolutely. And you will also look into the cost as we have discussed. When the generics come in, I think there will be a lot of use of Palbase compared to ribociclib.
Is going to increase in times to come. That is right. That is right. That was a question from Dr. Goel. So, what about Dr. Tarachand's views about the visceral metastasis and your experience with these patients in CDK4/6 inhibitors used, Dr. Yogesh? Visceral metastasis patients, do they do well, or is it only the bone metastasis patients in real world? The trials say that visceral metastasis patients were included to the tune of about 40 to 50%, and they did equally well. So, what is your take on this?
True. I think in real practice also, I have used in people who have got low burden visceral disease, and they have done well as well. So I think it's a matter of how much burden of disease they have in the viscera. I think go by that.
Okay, Dr. Abhishek, visceral metastasis in your practice, have you been able to tackle visceral metastasis only with CDK4/6, or are you tempted to give chemotherapy in a patient who has got full-blown liver disease, liver metastasis, for example?
No, as long as a patient is not having visceral crisis, they do well with the some supportive care.
Okay.
Some supportive care, they do well with CDK4/6 along with the hormone endocrine therapy.
Okay, Mehdi sir, your experience, visceral metastasis patients, do they do well?
Yeah, I am comfortable. I have used in many patients with visceral metastasis, but results are not bad. It is encouraging.
What I am saying,
Just a minute.
my experience in the last 4 or 5 patients, the patients are hardly crossing 1 year PFS in patients with visceral mets.
So PFS will definitely be lower if the visceral metastasis is on the high side. But very importantly, I want to ask which drug, Dr. Mehdi, which drug, Palbase, Crixana, Ramivin, if suppose you have a patient who has got diffuse liver metastasis and ER100, PR100, HER2 negative, any particular drug you would like to go to out of the 3 available?
I think in liver metastasis, I have the more experience with palbociclib, because palbociclib came early and I have used more palbociclib in liver metastasis.
Okay. Dr. Tarachand?
I would support Dr. Mehdi that in a liver mets, usually I will not prefer the ribociclib because it has also the side effect like transaminases that may happen anytime, and I have to stop. Even the liver mets, if the patient may end up in the visceral crisis, then it will be a problematic. And yes, patients with the GI mets like a liver and etc., patients are at high risk of diarrhea or other things. So it may be also a troublesome for the patient. So I will go with the palbociclib, which is quite safe in both these conditions.
So very interestingly, 5 minutes back, everybody was in favor of Crixana, and now suddenly everybody is in favor of Palbase. So I'm not getting one answer. And I really want to now come to Dr. Srijna. Liver metastasis, what is going to be your preferred choice? Are you scared of Crixana in liver metastasis? Are you wary of using Crixana in liver metastasis?
But in contrary, I have heard previous talks on this, sir. I learned that in liver metastasis, Crixana works better, surprisingly.
Okay.
That's my experience as well, Rajat.
That talk must have been from Novartis. So Dr. Yogesh is also saying the same thing.
Even I have the same experience, except for few transaminases. Even in liver metastasis,
and Dr. Trivikram.
So my preference will be ribociclib only, Crixana.
Ribocyclib. Trivikram has come out thinking that I'm not going to talk anything else but ribocyclib. So see, the thing is that I want to ask anybody who's in favor of using abemaciclib in liver metastasis. We have the data from Monarch 2, which Monarch 2 certainly is a second line therapy with fulvestrant, where liver metastasis patients had a hazard ratio of 0.6. Where else did you get a liver metastasis hazard ratio of 0.6, whereas bone only metastasis patients were hazard ratio of 0.9. So liver metastasis, abemaciclib, anyone has got experience of using abemaciclib in a bad liver disease patient? We're talking about visceral, not in visceral crisis. Anyone, any panelist would like to take up the question of abema?
Rajat, no experience, but if it will be available to me, I'll definitely use abema in liver metastasis.
So okay, very important point from Dr. Rajiv Seni. So abemaciclib works very well in liver metastasis patients. I can tell from my experience, about 5 patients out of the 9 abema that I have used till now have been liver metastasis in a very bad shape, and abema has been quite good with no toxicity whatsoever as well. So I think with Monarch 2 now being discussed a lot, we should talk about liver metastasis and abemaciclib as well. But of course, points taken well from the panelists that transaminitis can be an issue with ribociclib. Although liver metastasis and ribociclib, we have good data of Mona Lisa 3 also showing that in liver metastasis patients there was a good dent that Crixana could make. Next slide, please. So,
Dr. Rajat, just want to ask one question. Which one? I think the abemaciclib people is potent, quoting that the abemaciclib is very potent. So is it true that in 3 of the abemaciclib is very potent compared to the ribociclib or palbociclib? Based on these studies, or
yeah, I'll like to take, I'll just answer this question in a while. Give me 2 minutes. Next slide, please. So this we have discussed this. We're talking about the Falcon study. Next slide, where Falcon study people did agree that, but not a very. Next slide, please. Please go to the next slide. Can I have the next slide? Yeah, so we've discussed the first choice therapy as well, and people say that they have options of Palbase and Crixana, although they are ready to convert to abema if at all the patient has got poor prognostic factors, is what has come out of the discussion till now. Next slide. So we do understand and know that in ASCO 2022, we had Paloma 2 trial where they looked at the updated OS analysis, but did not find it to be superior in terms of the p-value, although numerically it was numerically it was better with compared to letrozole.
Sir, your voice is not audible, sir.
Delhi and UP, there is a heavy rainfall. I believe there is some network issue.
Rajesh, sir, can you hear me?
so
Sir, your voice is
I
not
think
audible, sir.
so I think we have covered all aspect that covered by the Dr. Rajat. So thanks for all panelists as well as Dr. Rajat. I think Dr. Rajat is there any connectivity with Dr. Rajat?
Sir, मैं एक बार call करती हूँ sir, but just give me a minute.
Dr. Rajat is connected to the oncology.
So I think Tarachan, so are you convinced with this palbociclib, ribociclib, or abemaciclib? So which one you prefer in your clinical practice?
Yeah, Devesh was,
Doctors have
this is
discussed-
not good. This is not good, Hana. I can ask the same question. You are not more. I can ask you the same question from yeah, this seat was of the Rajat only, so he could ask that.
I think in my view, my personal view. So I think after after the introduction of these generics, so I think the cost will come down, and most likely the usage of this CDK4 inhibitors is increasing more
There
than
is was one more
Yeah.
thing is
I think
that
Dr. Rajat have connected. Okay,
I
okay,
think
okay.
around
Fine.
10-15 days back, around 10-15 days back or 20 days back, there was an article which on the quality of life with the CDK4/6 inhibitors, and that went into the favor of ribociclib in comparison to the palbo or that means abemaciclib.
Sorry, Tarachan, Dr. Rajat have connected. So please complete, Dr. Rajat.
Yeah. So I'm back. So I was talking about abemaciclib, and especially when we're talking about second line, we have to talk about abemaciclib because we have the good data from Monarch 2, and very importantly, even the PFS in second line with abemaciclib is to the tune of 16 months, whereas with Palbase and Crixana it is about 9, 10, or 11 months. So a good delta of 5 to 6 months in second line in PFS is something that is quite tempting for us as a medical oncologist. Also, I will be very honest in saying that with abemaciclib, I had a lot of reservations when I started using it with the grade 3 and 4 diarrhea to the tune of 15%, all grade diarrhea to the tune of 75 to 80%. But then to my surprise, and then I have spoken to many other colleagues in in the fraternity, there has not been any mostly at the most grade 1 diarrhea patients, which is very well manageable. So diarrhea is not an issue. Abemaciclib is definitely a drug which is different from Palbase and Crixana. We have seen that in the adjuvant setting as well, and then we have seen that in the metastatic setting, be it the Monarch 2 or the Monarch 3 data. With primary endocrine resistance, I have got 2 patients where they progressed very quickly on the adjuvant AI, but with abema coming into the play, the patient achieved a near CR in the first PET scan. These are the 2 patients with a CNS metastasis. Patient achieved a near CR in the brain, although the patient did receive radiation. And I'm talking about a lot of patients who had poor prognostic factors, and they were given abema, liver metastasis, although not in visceral crisis, and abema has done well. Very recently, I started a patient of hormone receptor positive, HER2 negative, where the patient had bone marrow involvement. Although this is a visceral crisis and standard of care treatment is chemo, patient is 80-year-old. She did not want chemotherapy. We made them understand and took it in writing, started abemaciclib, and her platelets were 50,000 when it was started. Abema, we have the luxury of not really thinking too much about the hematological toxicity. The platelets have now become 1.5 lakhs after say about 5 to 6 weeks of therapy. So abemaciclib definitely is a good drug, and one should really resort to abemaciclib if we have poor prognostic factors. But then, of course, I am not here to talk only about abema. I am so sorry I got totally involved in the discussion. So coming back to Dr. Trivikram, what do you think about Monarch 2? Monarch 2 data PFS of 16 months. So does it really tempt you to prescribe abemaciclib in the second line with more PFS as compared to its counterparts, Palbase and Crixana?
Definitely, sir. I would like to definitely try abemaciclib, even though I haven't used it till now. But definitely, I would like to try abemaciclib in that setting.
Okay, so if I have been able to move Dr. Trivikram from ribociclib to abema, I think it has made some difference. And Dr. Tarachan, what do you think? Second line Monarch 2 data, 16 months PFS, Dr. Tarachan? Dr. Tarachan, is he there? Dr. Abhishek?
Yes, it is quite interesting data, and I have used abema in one of my patients, where the similar way you were saying that after first PET, patient had even CR in the brain mets also. So I have used so far one patient who had brain metastasis. In that patient, I have
Okay.
used, and quite amazing.
Mehdi sir. Okay, right. Dr. Mehdi, sir,
Yeah,
your experience
yeah.
and what is
After
your take second line? If we're talking about second line.
yeah, for second line, after seeing data, probably I would change my mind from palbociclib to ribociclib to abemaciclib now. So this is your credit.
Okay. No, sir, of course not. Dr. Srijna, I would like to now play a devil's advocate and talk about Monarch 2 here. And when I'm coming to you, I'm talking about a PFS of 16 months with Monarch 2. Would you like to really elaborate on why the PFS of 16 months has come with the abemaciclib plus fulvestrant in Monarch 2? Any thoughts on that? Dr. Srijna?
Probably they have taken a better subset of patients, sir.
So what was that better subset? So Monarch 2 patients, they were not allowed to have any chemotherapy in the metastatic setting, none at all, and they were allowed to have only one endocrine therapy in the first line. So it not even two were allowed. So definitely their subset of patients were better. But having said that, very importantly, a liver metastasis hazard ratio of 0.6 is certainly very important for us to remember as medical oncologists. Again, very importantly, we have to understand the concept of endocrine resistance. Primary endocrine resistance patients having a hazard ratio of 0.65. Where else would you see? Primary endocrine resistance patients have not been included in any trial whatsoever. It is only Monarch 2 where they have been covered, and a hazard ratio of 0.65, which is even better than secondary endocrine resistance where the hazard ratio is 0.8. So important point is that abemaciclib should be used for bad prognostic factors, and the diarrhea part should not really be worried about. Probably Indian patients' diarrhea is not something which is very important. This is what I have come to know, and I've talked to some of my colleagues. So maybe things can change in times to come. Next slide, please. Next slide, please. Yeah, so we do understand that endocrine sensitive group does better. Dr. Srijna has already spoken about this. Next slide. We've discussed this part. Next slide. Yeah, next slide. Premenopausal women, most of the panelists have agreed that they would like to go with Mona Lisa 7 and prescribe Crixana, although Paloma 3 also in premenopausal patients did have a subset which was an unplanned subset where it showed that there is a benefit. So Dr. Rajiv Saini, in your clinical experience, the toxicities definitely are important, like you said. So you said that experience with Abema probably is right now not there, but any rare side effect you've experienced with CDK4/6 inhibitor in your practice, Dr. Rajiv? Hello, Dr. Rajiv, are you there?
No, sir, he left.
Okay. Dr. Yogesh, any rare side effect in your practice?
Nothing so far, just the usual neutropenia. So nothing.
Okay, anybody who can come up with any rare side effect, anything? Anyone? Dr. Sudhir, Dr. Trivikram? Mehdi sir?
Yeah, although not rare, but I have experience of facing with palbociclib. One patient had severe neutropenia and she had severe UTI, and that was not only once but two occasions. And I reported, I discussed this thing with the company also, but later on found that in rare cases, maybe neutropenic period, patient might catch infection and maybe some other comorbidity. Because of that, maybe febrile neutropenia may be seen. Although commonly with neutropenia with CDK4/6 inhibitor, febrile neutropenia is rare.
Dr. Rajat, sorry, just want to interrupt. I think time is going on. 15 minutes more discussion.
I'll just take 2-3 minutes more. Just 2-3 minutes more. So, Dr. Abhishek, what is the FDA warning with the use of CDK4/6 inhibitor? Any idea about the FDA warning with the use of CDK4/6 inhibitor? Anyone?
Before that, I just wanted to mention that one of my patient who was on ribociclib, that patient, she had a severe myalgia. It was unexplained. Somehow I gave all the medications to control her myalgia, but myalgia was grade 3, grade 4. Sometimes she told that once I take this tablet, after half an hour, I used to have this pain. That was unusual for me. I don't know if somebody, one of you can suggest what was that. I mean, it was not beyond my explanation. After 1 hour of taking ribo, she used to have severe myalgia, which was
so I can think of is that one can check for magnesium and potassium, but then of course it can be one of the rare side effects of ribociclib. I've had patients who have had nephritis with both ribo and palbase. The serum creatinine has been on the higher side, and then once this drug has been stopped, the creatinine has come back to absolutely being normal, although this is not very much reported in literature. So an FDA warning is there with all CDK4/6 inhibitors, which we as oncologists may not really give a due cognizance, which is that 1 to 2% there is a risk of pneumonitis, and we should all take this into account when we are having the CDK4/6 inhibitors. And any cough which is there, it should not go unnoticed, and we should really scan the lungs to see whether the patient is having pneumonitis or not. Dose reductions is something which is not required in both renal and hepatic dysfunction, is again a very important point for us to know. Next slide, please. So this Pearl study, I wanted to bring across this point that in the Pearl study, in the second line, there was no difference between capecitabine and second line use of palbase. So Dr. Srijana said Young Pearl did say that premenopausal patients, the palbase was better with OFS as compared to capecitabine, but Pearl study pitched capecitabine along with palbase, and they were absolutely similar. So probably we have to use CDK4/6 in the first line. Another reason why Falcon study data is not having too much of meaning nowadays. If we use the best batsman in the first setting, then this is the best scenario for our patients. Next slide, please. So CNS penetration we have discussed. CNS penetration we've already discussed. Abema is better, although this is a phase 2 study. About 24%, 25% response rates on CNS with abemaciclib, palbase, and Crixana. Only retrospective studies more with Crixana than palbase. Some effect on CNS is there with Crixana. Primary endocrine resistance population, very important point. Monarch 2 study, hazard ratio of 0.6. Primary endocrine resistance, we have to really segregate our patients in that way. Next slide. And of course, visceral crisis, there is a good article by Dr. Shaina Dawood, which has been published in February 2022, where they have taken 150 odd patients with visceral crisis. They've given CDK4/6 inhibitors. We do understand it is not the standard of care. The response rates in that retrospective study have been to the tune of 60-65%. So patients who cannot take chemotherapy, some patients who may not be having a good performance status, age may be an impediment. We can certainly resort to CDK4/6. And here also one would like to probably think that Abema being the good drug for the bad disease patients, probably Abema scores more, although I don't have evidence, but probably yes. I've treated one patient, bone marrow involvement, she's doing well. Maintain study we've discussed already. Dr. Srijana, your last comments on maintain study. What is the criticism of this study? This study, although a very small number of patients did tell us that CDK4/6 inhibitors beyond progression work well. So do you think that we should take this into account? If we look into the deeper aspect of the study, they have not really told us as to when did they actually consider it to be a real progression, because many a times few things here and there we don't really consider when we are giving patients CDK4/6 inhibitors. What are your comments? We are closing in 2 minutes.
Yes, it's a phase 2 study and a short follow-up study. I think a phase 3 study is required for the confirmation of this data. In few patients, we also tried to switch the therapy and continue the CDK4/6 inhibitors, but most of the patients progressed in 3-4 months only.
Okay. Right. Next slide. Yeah, okay. I think so. We come to the end. So, Dr. Mehdi, what are your final words, sir? Please, your final thoughts on CDK4/6 inhibitors. Are they here to stay?
The CDK4/6 inhibitor has got established role, and now in hormonal positive and HER negative metastatic breast cancer, first choice in absence of visceral crisis. My first choice, and I think it is already established, and aromatase inhibitor and CDK4/6 inhibitor is the standard of care.
Okay, right. Dr. Yogesh, what are your thoughts? CDK4/6 inhibitors, definitely the right way to go?
Yes, I would agree with Dr. Mehdi. Yeah.
Okay, okay. And then final comments from Dr. Sudhir. He's been quiet for quite some time. Dr. Sudhir, are you there?
Yeah.
Dr. Sudhir, CDK4/6 inhibitors.
Yes, sir. CDK4/6 inhibitor are here, and with the new arrival of abemaciclib, there are the more approach toward the visceral meds also for these patients.
Right. So the summary is that all my expert panelists agree that CDK4/6 inhibitors is a very important cog in the wheel in the treatment paradigm of advanced metastatic breast cancer, which is hormone receptor positive, HER2 negative. Palbase and Crixana can always be debated upon. There are few bad prognostic factors for which abemaciclib can be looked at. Overall survival certainly is important. And with coming in of the generics of Palbase, things are going to change in 2023. But certainly it is going to be good for our patients who are always in financial crisis when we're talking about the oncology treatment. With this, I thank the organizers, Dr. Goyal, and all the organizing team members for having me here. I especially thank all my expert panelists for taking out their time and really helping us navigate through all these important discussion points for CDK4/6 inhibitors. And with this, I hand it over back to the organizers. Thank you.
Thank you.
Thank you.
Thank you all panelists, Dr. Srijna, Dr. Trivikram, Dr. Mehdi sir, Dr. Yogesh, Dr. Abhishek, Dr. Tarachan, Dr. Sudhir. And without our interest and company interest, we have discussed each and every aspect independently. So thanks, Dr. Rajat, for wonderful discussion. So for last topic on discussion, that is INTAS sponsored session. So I invite Dr. Tarachan Gupta. He is medical oncologist in Bhagwan Mahavir Cancer Institute, and he will deliver the talk on this role of bone modifying agents in treatment of bone metastasis, the focus on denosumab. So over to you, Dr. Tarachan.
Thank you, Deveshwas. And I start my presentation. Yeah. So I hope my slides are visible. My slides are visible?
Yes, yes, yes. Dr. Tarachan. Go ahead.
Okay. So the topic is also quite yes, it is for the quality of life of the agents in treatment of bone mets that we have like zoledronic and denosumab. So I will focus now in this talk only. So denosumab is
sir, sorry to interrupt, but I think
yeah, please.
Sir, your voice is not audible properly, so maybe there is some network issues from your end.
No, yeah, I think
right now, okay. Right now, okay, please.
Okay, it's okay. Deveshwas? Okay, I continue.
Yeah, okay, please continue.
Yeah. So the denosumab is a rank ligand inhibitor, which works by preventing the development of osteoblasts. And this is actually the mechanism of action, or you can say mechanism how the bone lytic lesions happen. Because when the tumor cells produce the factor, that is stimulate the osteoblast to secrete the rank ligand, and the rank receptors are present on the osteoblast. When these rank ligands bind to the these rank receptor on the osteoblast, these cells get activated and causes the bone resorption. What does the denosumab do? It binds to these rank ligand inhibitors, and so it comes in between the rank receptor and the rank ligand, and thus it inhibits the activation of the osteoblast, and subsequently the bone resorption is prevented. So if we see that usually the every man, you can say maximum of the cancer or the malignancies are having present with the bone mets also, and usually the prostate cancer having the sclerotic bone mets, while the breast and lung are having mixed type of the bone mets, lytic and sclerotic, and the thyroid and multiple myeloma and quite a good extent renal cell carcinoma presents with the lytic bone mets. So usually the 65% of the women with the breast cancer presents with the bone mets, and then develop the bone complication in the placebo-controlled trials. And the 49% of men with prostate cancer and bone metastasis develop the bone complications. And myeloma, it is 70% or more. So multiple myeloma is weakens the bone and puts the patient. So usually many patients with solid tumors are at immediate risk. That 1 out of 4 patients suffer for the bone complication if they have the bone mets. While in 3 months, it is 1 out of 3 patients suffered for the bone complications. Bone complications are so known as the skeletal related events and are defined as the patient requiring the radiation to the bone for the either the impending fracture or for the pain. Or second, maybe the patient may present with the pathological fracture, or patient may need surgery to the bone, or patient may present with a spinal cord compression. These all comes under the skeletal related events. So what I want to say here that why we should prefer denosumab over the zoledronic acid, because it prevents the skeletal related events, and which I will prove in my subsequent slides. This study which I have is on the screen is a combined analysis of 3 pivotal randomized phase 3 trials. These are the trials where it was compared by one is the David Henry when advanced cancer of multiple myeloma it was done. One was done in the breast cancer by the Allison topic, and another is the prostate cancer by the Fijay. So in the breast cancer or prostate cancer or other solid tumors, the patients were randomized to the denosumab 120 milligram subcutaneously. That is also a benefit of the denosumab over the zoledronic acid. It can be given in subcut form and zoledronic acid IV form. So placebo, subcut every 4 weeks. These were compared. So this primary endpoint was the time to first on study skeletal related event. This was primarily a non-inferiority design, but the second endpoints were the time to first and subsequent on study skeletal related events. That is a superiority. This was the superiority trial, like in the secondary endpoint by the superiority endpoint. If the primary endpoint of non-inferiority was met, the superiority test for secondary endpoints was conducted. It was already a planned study. If at the baseline, if one of the secondary endpoints was not met, statistically penalty was applied to the other secondary endpoints. So this is the we can see in the graph in this studies that the first skeletal related events time was 27.7 months in the denosumab arm, while it was 19.5 months in the zoledronic acid arm, around 8 months difference. So this is a graph is showing that there was at 3 months it was 10.4% lower skeletal related events, which increased to 12.4% at 1 year, while it is 16.2% difference when with the denosumab in comparison to zoledronic acid in the skeletal related events. So this observation these results were observed across all these tumors where the skeletal related events were 15% reduction in more than 15% reduction in the comparison to the zoledronic acid in the breast cancer, prostate cancer, other solid tumors, or the multiple myeloma, highest in the breast and prostate where it was 18% reduction. So these skeletal related complications, if we see that or you can say nice study which is comparing one by one all the molecules that if we don't give the bisphosphonate at the baseline, there is a 64% risk of skeletal-related events at 2 years, while pamidine reduce it by the zoledronic acid, further reduction of 20% in comparison to the pamidronate, and yes, the final one, the denosumab, which also reduced the skeletal-related events by 18% risk in comparison to the zoledronic acid. So this is the integrated analysis of the denosumab, and we can say that in the breast cancer risk reduction and time to first skeletal-related event was 18%, and other subsequent events it is 23%, and prostate cancer, other solid tumors, and other tumors, we can see the same pattern here in favor of the denosumab. If we come into the NCCN guidelines also, that is widely accepted across the globe, where it is also approved denosumab with along with the zoledronic acid, where it is kept on the priority by the NCCN. It is a category in the preferred option, denosumab in the bone mets patients. So thank you for patience listening. I will be happy to answer if there is any question. Thank you.
Thank you, Tarachan. So just my query. So in which do you prefer if the patient is okay? So do you prefer, is there any difference? Do you start apparently denosumab over the zoledronic acid? Is there any preference in your clinical practice?
Yes, Devesh was, this is the quite burning question that for the denosumab or zoledronic acid, yes, there is a 18% difference with the skeletal related events, but yes, if the cost is not the matter, then yes, I will go with the denosumab. There are 2-3 things. It is better molecule than the zoledronic acid in terms of the skeletal related events, and second, it is quite compliant is there that it can be given subcut patient, no need to put the cannula, or it can be taken at home like an insulin. So yes, if the patient preference goes with the finance, and I will go with the denosumab.
So I think I am convinced with this, if we can use, if there is finances is no concern. But one concern is in my mind with this denosumab, there is hypocalcemia after the starting this after giving this drug. So hypocalcemia is in my mind. So how you manage? Are you afraid with this hypocalcemia?
Yeah, what is the what my understanding is that these all are the calcium reducing agents, and either the bisphosphonates or the denosumab, and usually we are managing multiple myeloma type hypercalcemia, or you can say malignant hypercalcemia, with the use of the bisphosphonate. So yes, it is the feature of these molecules. So it is mentioned there in many guidelines other than myeloma that we should give the calcium and the vitamin D along with these molecules to compensate that. So I am usually giving along with the zoledronic also the calcium and vitamin D.
So definitely I am agree, and definitely it is better in terms of the reducing the first SRE. Even the SREs occur, so it will also delay the second SRE incidence. So I think the molecule is better subcutaneous preparations compared to the zoledronic acid, and it is also renal safe for elderly populations where the creatinine is high, creatinine clearance is below 30 or below 40. So the bisphosphonates cannot be using. So I think this drug is changing, and nowadays after the introduction of the generics, the cost is I think coming down. So we can use definitely. Is just a one-to-one question, or is are you using in the 3 months schedules, or compared to the monthly schedules in stable patients? Are you using the 3 monthly schedule or 6 monthly schedules with this hormonal therapy, or any other cases where?
If you are asking for the hormonal therapy, then it is for the prevention of the osteoporosis, not for the treatment purpose. Yeah, without the bone mets, then at this time I may ask the patient if they are comfortable with the pamidronate, and that means osteophos, or with the zoledronic acid, that is once in a 6 months. So or the denosumab, which can be used in for the prevention of osteoporosis that is caused by the aromatase inhibitors in particular. For other, if you are saying that in the bone mets disease, usually all the trials suggest that after the 1 year we can switch to the 3 monthly regimen of the zoledronic acid without compromising the efficacy or any survival or skeletal related events. So I am yes in practice with that. After 1 year, yes, I am definitely switching all the patients to the 3-monthly regimen. But anyhow, if you ask me that because it was the design of study where it was used monthly basis in that, and for the 1 year, then it was around either the Zoom study or other, then it was switched to the 3-month. But sometimes in the beginning, whenever the patients are on the 3-weekly cycles, then usually I go with the sometimes 6-weekly regimen. Whenever the patient comes, I give the first cycle, third cycle, fifth cycle, right, like this.
So just in malignancy,
Not any evidence for this, but this is an practice that I am accommodating the zoledronic acid with the patient's compliance for the chemotherapy, so that patient need not to come again for that. Yes, if I have to use the denosumab, I will ask that patient to use at monthly regimen. He can take at home. He needs not to come to the hospital.
So just last question. So we are using the 120 milligram. The 60 milligram dose is nowadays available. So I think if there is no metastasis and we are giving the lot of steroids in each and every malignancies. So is there any, are you using any concept or practice the every 6 months or every yearly this denosumab or zoledronic acid to prevent osteoporosis, where we are using steroids in clinical practice more and more? So if there is no evidence of bone metastasis,
for the steroids, if you are saying that these are the main part of only the lymphomas mainly or the leukemia, or you can do which we are using with the chemotherapy regimen. These are only the anti-emetic and the low dose only for the short duration only. So this may not going to cause the osteoporosis so frequently. For the purpose of steroid in the lymphomal leukemia, yes, there is a recommendation from the other thing that we should use the calcium to prevent the osteoporosis. But yes, bisphosphonates are still not. I think in my mind it is not recommended for the steroid for the threat of steroid induced, because in those malignancies also we are using for the short time only the up to the 3 months, 4 months, or 6 months, and we can compensate by the calcium only at the time.
Okay. So thank you, Dr. Tarachand. Very well discussed about this topic, that denosumab in this bony metastasis in various malignancy. So I think the today discussion on this breast cancer, we have discussed the first part, the trastuzumab deruxtecan. So very well discussed by the Dr. Asim. So we can use this molecule in HER2 low positive breast cancer, in metastatic breast cancer. So there is data is coming on, and I think in future years we are using these molecules in our India also, in every patients, each and every patient of HER2 low positive patients. So next come to the Roche sponsored session, that is the FAST-GO. So this is the combination of this trastuzumab and pertuzumab, and that is the subcutaneous available. So it is very easy to administer and can replace the IV preparations if the patient is affording and patient do not want to time consume. And the next, the TDM1, the journey though. So we are using in this adjuvant setting as well as in metastatic setting. So Catherine data is very well convinced. So if there is after neoadjuvant chemotherapy, if there is no PAT-CR, so if there is residual disease, can use in the adjuvant setting, and if there is in metastatic setting, definitely. So my choice can be used in first line, or if there is the preferences in second line after trastuzumab, if there is diseases progressing. And the third part, the very well discussed about the hormone receptor positive, HER2 negative, that CDK4 or CDK6 inhibitors. So very well discussed. There is no controversy and without a sponsored session. So I think there is no controversy. So very well discussed about this palbociclib, ribociclib, and abemaciclib in each and every patients where these drugs can stand. So we are using these molecules. The palbociclib as well as the ribociclib and abemaciclib. So nowadays abemaciclib is also launched. Next year's palbociclib is in the launching in this generic form, the various companies. So we all are prepared. Ribociclips can be used in premenopausal patients, and there is data is showing that ribociclib compared to the palbociclib, quality of life is still better with this ribociclib. And definitely in second line, after there is progression, if there is brain mets, so abemaciclib can be used. So very well discussed in panel discussion and topics by the Dr. Srijna and Dr. Rajat. And after the last topic by the Dr. Tarachand, the role of denosumab in this breast cancer. I think there is one more question to Dr. Tarachand. Average duration of time for the denosumab 20 milligram every 4 weeks, or drug used in patient with creatinine clearance less than 30 ml per minute. So can we use? So I think there is,
as you highlighted also that, which I forgot at the time, that it is a renal safe and can be given within the low creatinine clearance also. Second question for the denosumab, how long for the 120 milligram? Yes, we don't have the trials with the denosumab of the switching to the 3 monthly regimen, but yes, it is not possible every time to do a different trial for each and every drug which is coming that is better than other second one. So I think when it is better than zoledronic in reducing the skeletal related event, we can go with the pathway of the zoledronic acid, that after 1 year we can switch to the 3 monthly regimen.
So definitely your point is well taken. So after disease is stabilized, so we are giving for this 1 year, and then we are accommodate the patient through every 3 months as a maintenance. There is definitely no data, but we are disease is stabilized almost after 1 year. So I think we are concluding this today's sessions for first day, that is the breast cancer. I thanks to all speakers for giving the time and for my invitations, and thanks to Horizon for this doing this activity very planned way and planned way, and thanks to all the scientific partners for today activities. Thanks. Good night, Dr. Tarachand.
बहुत वैसे बहुत जोरदार कॉन्फ्रेंस अरेंज किया आपने, मजा आया, रिवीजन हो गया साला ब्रेस्ट कैंसर.
Yeah, thank you, Dr.
Thank
Tarachand.
you. Thank you, everyone. Thank you for joining. Good night. Good night, everyone.
Thank you, Ekta. Thank you, Shurbi.
Thank
And
you, sir.
thanks all.
Thank you, sir. Good night, sir.
Good night. Good night. We will meet tomorrow.
Tomorrow.
Yes,
Yeah.
yes, sir. Yeah, sure, sir.